the section Neuroanatomy, let us begin with the developing skull, where we'll be talking about some of the fontanelle and their clinical importance, also talking about their appearance and disappearance. And looking from the side view, the lateral view, we can observe in the intrauterine life when the skull bones are developing. As you see, this is the skull cap and the bones here are developing in membrane. We have the intramembranous ossification. So when the baby is born, these bones are yet developing, and between them there are some gaps. The membrane is still visible, which is supposed to undergo intramembranous ossification and form bone. So these gaps between the bones will be known as the fontanelle. There will be a fibrous membrane here. And when we are talking about this region, it is a gap lying between the bones. On the front we have the frontal bone, and on the posterior side we have the parietal bone. So between the parietal and frontal bone we are having this anterior fontanelle. We have got one posterior fontanelle also, which is now between the parietal bone and the occipital bone. So this is the posterior fontanelle. Then we have got one posterolateral fontanelle also, which is now lying between the parietal bone superiorly and occipital bone posteriorly and the temporal bone anteriorly. So this is what we are calling as posterolateral fontanelle. And then we have got one anterolateral fontanelle as well. This anterolateral fontanelle is lying between the four bones. On the front we have frontal bone, posterior superiorly we have parietal bone, posterior inferiorly we have the temporal bone, and anterior inferiorly we have greater wing of sphenoid bone. So this is the anterolateral fontanelle or the sphenoidal fontanelle. These fontanelle have some clinical relevance, like if the baby is having dehydration, and if you feel for anterior fontanelle, you'll find it is a bit depressed as compared with the normal baby, or sometimes it may be bulging out. In that case, it could be a clinical scenario of raised intracranial tension, because directly deep to this is the cerebrospinal fluid running in the subarachnoid space. Sometimes we have to take a sample and we can take it from anterior fontanelle, so your needle will be piercing the fibrous membrane, which is basically the primordium of the periosteum. Once a bone will form in the membrane, this fibrous membrane changes into periosteum. So your needle is going through the fibrous membrane, then you'll puncture the durameter and the arachnoimeter to enter the subarachnoid space, and you can aspirate the CSF sample from here. Now, once the baby is born, these gaps are going to be filled up. The bones will grow in the membrane and fontanelle will disappear and sutures will appear. The first fontanelle to disappear is the posterior fontanelle, which is disappearing at the age of 3 months after birth. So we can mention here number 1. Fontanelle to disappear is the posterior fontanelle at the age of about 2 to 3 months post-birth. And the second to disappear is the anterolateral fontanelle, which is also called sphenoidal fontanelle. Now, though some books will mention that it is disappearing at the age of 2 to 3 months after birth, but there are some authors who will mention it is disappearing at the age of 6 months post-birth. But it is second in number to disappear. The third to disappear in sequence is the mastoid fontanelle or posterolateral fontanelle. It is an average of 6 to 18 months. So we can take the middle value, that is 12 months. This is the third one to disappear. We can mention here the mastoid fontanelle at about the age of 1 year after birth. The last to disappear is the anterior fontanelle, which may be persisting at the age of 1.5 to 2 years. Now, to memorize these numbers, you can simply start from the one which is disappearing earliest. So let us say the posterior fontanelle is disappearing at 3rd month, number 3. Now you double it, 3 into 2, that is 6. So at the 6th month, you are mentioning the second one is disappearing. We are just multiplying by number 2. So 3 into 2, 6. At the 6th month, the next fontanelle is disappearing. Now multiply again with 2. So 6 into 2 is 12. 12 months. At the age of 12 months, the next fontanelle is disappearing. And you multiply this with 2. That is 12 months into 2. It becomes 24. And that is the time when the last fontanelle is disappearing. So 24 months, the anterior fontanelle is disappearing. So basically, just to memorize, though it may not be so precise, you can say 3 and 3 into 2, 6. And then 6 into 2, 12. And then 12 into 2, 24. Now, when the anterior fontanelle is disappearing, a suture will arrive here and it is called as bregma. We can see that in the next diagram. And at this place, after fusion, lambda suture will appear. The suture which appear here is called as asterion, as will be evident in the next diagram. And the one which is appearing at the anterolateral fontanelle is called as the pterion. Pterion has got some clinical relevance and we'll be talking about that as well. Let us look at the next diagram now. So here we are getting the bregma at the level of the anterior fontanelle, and at the level of posterior fontanelle, we have got the lambda, and posterolaterally, we have got the asterion. And when it comes to the pterion, it is H-shaped suture between four bones. On the front, we have frontal bone, posterior superior, the parietal, posterior inferior, the temporal bone, anterior inferior is the greater wing of sphenoid. And we are supposed to discuss some of the clinical relevance here. We understand that there is one artery supplying the bone maxilla, and the name of that artery is maxillary artery, which itself is a branch of external carotid artery. So external carotid artery giving the maxillary artery to supply the bone maxilla. From the first part of maxillary artery comes one artery called middle meningeal artery, passing through foramen spinosum at the base of the skull. It will enter the floor of the middle cranial fossa, and this middle meningeal artery is then giving two division, anterior division and posterior division. It is the anterior division which is passing deep to the pterion and might be bleeding when there is a fracture in the skull. Say for example, there is one motorcyclist meeting with a road traffic accident, and since there was no helmet on the skull, the weakest point of the skull pterion is broken. Deep to that, this artery is bleeding, the anterior division of middle meningeal artery, leading to extradural or epidural hemorrhage, and that is one emergency situation. You will immediately take a CT scan, and in the CT scan you will find one ominous sign, a biconvex shadow, and that biconvex shadow is because of the collection of blood hair bleeding from the middle meningeal artery anterior division deep to the H-shaped suture, the pterion, and this is called extradural or epidural hematoma because it is outside the membranous layer called dura mater. Now you have to consult with the radiologist, and it might be advised that this hematoma has to be evacuated. These patients, as they meet with the accident, they will have loss of consciousness, but then they might gain the consciousness, which is lucid interval, so as to once again have the loss of consciousness, and this time they might not come back, means we might lose the patient. So lucid interval is a characteristic feature of a patient having the extradural or epidural hematoma. And then we have got one more importance of this H-shaped suture, the pterion. It is lying over a point which is called as the Sylvian point. And this Sylvian point is basically the beginning of the stem of the lateral sulcus, which itself is called as the Sylvian sulcus. So this is the point which is lying deep to the pterion. And that is why deep to the pterion, the Sylvian point is the beginning of the stem of the lateral sulcus on the brain, the sulcus which is separating the frontal lobe of cerebrum from the parietal lobe of the cerebrum. As we look at the skull at birth, there are some of the components which are of adult size, and we want to have a look upon them. To enumerate the structures which are of adult size at birth will be the tympanic membrane, which is separating the external ear canal from the middle ear cavity. The middle ear cavity is inside the tympanic cavity, which is a space in the temporal bone. So even the tympanic cavity is of adult size at birth, and its component like the ear ossicles, malleus incus stapes, even they are of adult size at birth, means they do not grow once the baby is born. And when it comes to the tympanic antrum, which is a communication of the tympanic cavity posteriorly, even that is not growing after birth. And yes, the internal ear having the several components are of adult size at birth. Now we are going to look at some of the structure which are yet to grow and they are not at adult size at birth. The tegmen tympani, which is the roof of the middle ear cavity, is going to grow after birth. And when it comes to mastoid process, it will appear after birth of the baby. Same is for the external ear and the external ear canal. They keep growing after birth. Eustachian tube, which is connecting the middle ear cavity with the nasopharynx, also grows after birth. And one more thing you can add here is even the orbit. As you mentioned, the orbits are not of adult size at birth. They are going to grow after birth. And next we move on to the development of the nervous system. The nervous system is actually developing from the ectoderm, which is called as the neural plate ectoderm, can be seen in the next diagram. And for that, we are looking at the dorsum of the developing baby. In the beginning, there will be one neural plate, which becomes a neural groove and gradually becomes a neural tube. So let us draw it here. On the dorsum of the baby, first we are having a neural plate, and gradually this neural plate is going to become a neural neural groove and neural tube. The neural tube will be open at the cranial or rostral end and also at the caudal or the posterior end. Here we are calling it as the anterior neuropore, which is supposed to close after some time, and this is the posterior or the caudal neuropore. The anterior neuropore is going to close at day number 25, which you can mention, and as it is closing, anteriorly or cranially develops the brain, whereas after 3 days, that is day number 28, the posterior neuropore will close and caudally develops the spinal cord from the neural tube. So posterior neuropore closes at day number 28 so that spinal cord is forming on the posterior or caudal side. And the same structure you can see, dorsal view of the baby having a neural plate, then there is a neural groove formation, and then there is a neural tube formation. Seen in the last diagram is the neural tube having one anterior or cranial neuropore and posterior or caudal neuropore. You can mark them here as well. This is the anterior neuropore closing at day number 25, and this is the posterior neuropore which is closing at day number 28. If they do not close, there can be problems which are called as open neural tube defects. But before we start discussing them, let us take a transverse section here on the neural plate, and as we are doing it, you can see this is the neural plate on the dorsal side of the baby. This neural plate becomes a neural groove, and then it is detaching from the dorsal surface, comes ventral, and as it detaches from the dorsum, comes ventral, it becomes a neural tube. So as we are marking it at the beginning, we are telling it is a neural plate. We have to remember the neural plates start forming only when there is stimulation by this notochord. So notochord is going to stimulate the overlying ectoderm to form the neural plate ectoderm, and then this neural plate ectoderm is becoming a neural groove as is evident here, and this neural groove is going to detach from the dorsal surface and then it is becoming a neural tube, and this neural tube is quite a long tube. Actually, as we have mentioned, this neural tube is cranially going to form the brain and caudally going to form the spinal cord. That is the central nervous system. Then what about the peripheral nervous system? The peripheral nervous system will be coming from the neural crest cells which are appearing here on the periphery of neural plate. Beyond that is surface ectoderm. So at the junction of surface ectoderm and neural plate ectoderm, there are some neural crest cells developing, and these neural crest cells are also going to detach from the dorsal surface. As they are detaching, they will be lying dorsal and lateral to the neural tube and forming the peripheral nervous system. So let us mark them as well. As we are talking about the neural crest cells, as evident here, they are also detaching from the dorsal surface and they are now lying dorsal and lateral to the neural tube. And these neural crest cells, they are going to contribute to peripheral nervous system. They form most of the ganglia. For example, dorsal root ganglia, sympathetic, parasympathetic ganglia, pre-aortic, para-aortic ganglia. Most of the ganglia come from neural crest cell. Now we were talking about the closure of the neural tube which happens normally. What will happen if there is non-closure of anterior neuropore and encephaly? And what about the non-closure of posterior neuropore? It is called as racheschisis, which we will be discussing in the next diagrams. So as we talk about the open neural tube defects, we have some photographs with us. This is a baby with an encephaly, non-closure of anterior neuropore. So there is a small brain which is degenerated and there is a missing skull cap as well, a case of an encephaly. On the other hand, if there is a non-closure of the posterior neuropore, then in the lumbosacral region, what we find is spinal cord is not developed properly and actually it is open. So open spinal cord, CSF is leaking out, even the vertebra is open, which is called as spina bifida, and the skin covering the defect is also open. So what you find here is skin is missing over the defect and some CSF is leaking out. If you take a transverse section, you'll find in a case of racheschisis, the spines have not fused. As we understand, the vertebra develops in right and left halves. Later they get fused. So when there was a fusion about to happen in the right and left half of the vertebra, there was no proper fusion. The spine are bifid, they are open. And why they are open? Because the neural tube itself is open. You can see the neural plate has become neural groove, but it has not become the neural tube properly. That is why the CSF is leaking out and skin remains at the periphery. Skin is unable to cover this area, which normally should happen. So this is spina bifida with racheschisis, one open neural tube defect due to non-closure of the posterior neuropore. We can prevent such defects by giving a prophylactic prophylactic, folic acid to the ladies who are going to become pregnant, and it should be given prenatally, natally as well as postnatally. 400 microgram per day of folic acid prophylaxis, which will prevent the occurrence of open neural tube defects. Now, some of the babies will have both of them. The entire neural tube is open, and that comes in the exam when there is a total non-closure of the neural tube. That is a combination of anencephaly plus rachis, which is called cranio-rachis. The examiner will give you this photograph and you have to identify the anomaly. You see there is skull cap missing, a small degenerated brain, feature of anencephaly, and then there is an open spinal cord, open vertebra, spina bifida, and skin remains at the periphery. It will never cover the defect, and CSF keep leaking out the rachis. So rachis plus anencephaly, together we are calling it as cranio-rachis. Then we have to talk about different types of spina bifida. The spina bifida could be spina bifida occulta, which is the most common type, and it is called as the occulta because it is hidden, not evident clinically. Patient in the lumbosacral region might have a tuft of hair and nothing more evident. But deep to that, there is a bifid spine, spina bifida. Though the spinal cord and the meninges, they are within the limits of the vertebra, and this kind of situation is asymptomatic, often found incidentally while you were taking some x-ray and you found this patient is having spina bifida, but it is occult. And since it is asymptomatic, you are not supposed to do anything with the patient. Now, this is the occult type and the most common. The least common is the spina bifida with rachis, which we have just discussed. Non-closure of posterior neuropore in the lumbosacral region. The CSF was leaking out. Skin remains at the periphery. So, rachis is the least common variety of spina bifida. Then, what about the middle two? That is B and C. These are spina bifida manifesta because they have manifested. They are also called spina bifida cystica because there will be a cyst on the skin. So in the lumbosacral region, you will find there is a spina bifida cystica. Now it depends whether the cyst is having only the meninges. In that case, you will say meningocele, or some neural tissue has also come, which makes it meningomyelocele. So spina bifida cystica, which can have only the protrusion of the meninges, and spinal cord is still within the limits of the vertebra. So this is a case of meningocele, spina bifida cystica with meningocele. Then what is meningomyelocele? Meningomyelocele means the meninges as well as some neural tissue, that is diagram number C, has come outside into the cyst. So this is the skin which is showing a protrusion, basically a cyst, and in the cyst you are having the meninges and spinal cord has also moved into here. So neural tissue is also there. When you are taking one syringe and you are aspirating, you will get some CSF, but there is some markings, blue, black, brown markings. If it is a clear cyst, then meningocele. But if it is having these markings, now some neural tissue is there, we will call it as spina bifida cystica with meningomyelocele. It's not a clear cyst. And what you notice is not only the vertebra is open, through the vertebra, meninges have come out, part of the neural tissue, the spinal cord tissue has come out on the dorsum of the baby in the lumbosacral region. So this is spina bifida cystica with myelomeningocele. As you puncture it with a needle, you can aspirate the CSF, and if it was a clear cyst, only meningocele. But if it is a cyst with neural tissue, as evident with these darker areas, then it is called as myelomeningocele. Along with the developing central nervous system, we'll be also looking at the ventricles, the open spaces which are within the CNS containing the cerebrospinal fluid, which is ultrafiltrate of blood secreted by the choroid plexus, some capillary plexus, which are projecting inside the ventricles. So in the beginning, we have the neural tube, and that neural tube is going to form the 3 primary vesicles, which later become 5 secondary vesicles, and then they'll be giving some adult components which are themselves developing some of the ventricles. We have to talk about that. Ventricles are the hollow inside the central nervous system. Now, the neural tube, which is supposed to give us the brain and the spinal cord, in the brain we have the three primary vesicles, the forebrain, midbrain, and the hindbrain. The forebrain is also called as the prosencephalon, and the midbrain is the mesoencephalon, and the hindbrain is the rhombencephalon. It is the hindbrain which will then continue as the spinal cord downwards, which is evident here. So, it is the prosencephalon, mesencephalon, and the rhombencephalon, which then continues downward as the spinal cord. Now, the forebrain or the prosencephalon divides into telo and diencephalon, which you can mention here, the secondary vesicles, whereas the midbrain does not divide, it remains as the midbrain or mesencephalon, whereas the hindbrain is divided into two components. One is the metaencephalon, the other is the myelencephalon. And when it comes to the telencephalon, it is giving us the cerebral hemispheres and the basal ganglia. Even cranial nerve number 1, that is the olfactory nerve for smell pathway, belongs to the telencephalon part of the forebrain. In the forebrain, we also have the diencephalon, which is thalamus and related thalamus. Could be hypothalamus, metathalamus, subthalamus, and even the retina and optic nerve. They are part of the diencephalon. So cranial nerve number 2 belong to the diencephalon part of the forebrain. So it is basically thalamus and the related thalamus plus the retina and optic nerve part of the diencephalon. This is cranial nerve number 2. And when it comes to cranial number 3 to 12, then they'll be coming from the brainstem. Brainstem has three components: the midbrain, pons, and the medulla oblongata. So when we are talking about the midbrain and the pons and the medulla oblongata, they are going to form the brainstem, and in the brainstem we are having cranial nerve number 3 to 12. Now, as we were talking about the mesencephalon, it is the midbrain. The hindbrain, that is the rhombencephalon, was dividing into metaencephalon, myelencephalon. In the metaencephalon, we have got pontocerebellum, pons plus cerebellum, whereas the myelencephalon part of the hindbrain will be forming the medulla oblongata, and medulla oblongata inferiorly will be continuing downward as the spinal cord. Now let us look at their ventricles as well. It is the forebrain having telencephalon, the cerebral hemispheres, which will be having the lateral ventricles, ventricle number 1 and 2, right and left. So one of them is going to right side, one of them is going to left side, as you can see here in the diagram. This is the right and the left ventricle, ventricle number 1, ventricle number 2, also called as lateral ventricles, the ventricles of the cerebral hemispheres. They are the largest of all the ventricles, and they will have most of the choroid plexus, which is the capillary plexus, going to form the CSF. They are filled with largest amount of CSF. So we have got ventricle number 1 and 2, right and left, also called lateral ventricle, the cerebral hemisphere. What about the thalamus? The ventricle of diencephalon, sandwiched between the two thalami, will be a midline ventricle, that is the third ventricle. So as you are marking here, you can mention this is the midline ventricle, that is the third ventricle. It is the ventricle of the diencephalon and is sandwiched between the two thalami on either side. So there will be one thalamus on right side, one on left side. Sandwiched between the two is the third ventricle, a midline ventricle, the ventricle of diencephalon, part of the forebrain. And it is the diencephalon which is extending into the eyeball to form the retina and the optic nerve. So optic nerve, the nerve of vision, is the nerve of the diencephalon, whereas the cranial nerve number 1, the olfactory nerve, is the nerve of telencephalon. It will be attaching here. You can show them, and they are supposed to carry the olfactory pathway. So here is the cranial nerve number 1, or the nerve of the smell. Now, once you have shown the cranial nerve number 1 and cranial nerve number 2 coming from the retina of the eyeball, the number 3 to 12 are coming from the brainstem. Then what is the ventricle of the midbrain? It is also a midline ventricle called as cerebral aqueduct of Sylvius, which you can show here. It is going to connect the third ventricle with the fourth ventricle. Fourth ventricle is the ventricle of the hindbrain. So as we are mentioning here, in the midbrain, we are having the cerebral aqueduct of Sylvius, which is a midline ventricle connecting the third ventricle with the fourth ventricle. And when we are talking about the fourth ventricle is the ventricle of the hindbrain, partly in the metaencephalon, partly in the myelencephalon, means lying in the region of pons and the medulla. It is a diamond-shaped ventricle, as is evident here, and is actually sandwiched between the pons and medulla anteriorly, whereas cerebellum will be forming the roof posteriorly. So cerebellum on the posterior side and pons and medulla on the anterior side, sandwiched between the two, is the fourth ventricle, diamond-shaped ventricle, which is then continuing into the lower medulla as central canal, which then continues downward into the spinal cord as well. So as we see, the fourth ventricle becomes the central canal, and central canal is present in the lower half of medulla oblongata and then continue in the spinal cord. So CSF is flowing from cranial direction to the caudal direction. As we have mentioned, most of the CSF is formed by the choroid plexus in the lateral ventricle, but choroid plexus also project into the third ventricle, forming some CSF there, and it is also projecting into the fourth ventricle, forming additional CSF there. And this CSF partly will be escaping into subarachnoid space. To escape that, on the roof of fourth ventricle, we have got some opening, a midline, which is the Magendie opening, and two lateral, which is the Luschka foramina. So there are two Luschka foramina which are lateral, L for L, and one midline, Magendie foramen, M for M. Now what is happening through this midline Magendie foramen and two lateral Luschka foramina at the roof of the fourth ventricle? The CSF is escaping out from the ventricles and then moving into the subarachnoid space. It will be running in the subarachnoid space, and then biarachnoid villi will be absorbed by dural venous sinuses, which we can see in the next coming diagrams as well. But at the moment, what we have to understand is that in the beginning, neural tube is a straight tube. Later, as there is a cephalocaudal folding of the baby, even the neural tube is folding and it becomes C-shape. There are several structures in the brain which will be taking C-shape. So let us look at the next diagram to describe the same. Here we are looking from the lateral view of the developing brain, and as we have mentioned, during the cephalocaudal folding, the straight neural tube is also folding and it is some part of the brain becoming C-shape. In fact, the skull cavity is a very limited space, and if the brain wants to grow, it should become spherical. So it is trying to become spherical. As you will see, the cerebral hemisphere, the largest part of the brain, has become C-shape, and the lateral ventricles which are inside the cerebrum are also becoming C-shape. Now the cerebrum is going to have one frontal lobe, as is evident anteriorly on the front, and then one posterior lobe, which is occipital lobe. In between there is one P, that is the parietal lobe, and inferiorly there is a temporal lobe. And inside the cerebral hemisphere, one on each side, there will be lateral ventricles. These are the lateral ventricles which themselves have become C-shape. Will have a horn, anterior frontal horn, posterior occipital horn, inferior temporal horn, and choroid plexus mostly is found in the lateral ventricle, forming the ultrafiltrate of blood, the CSF, though choroid plexus is also present in the midline ventricle, third ventricle, partly in the fourth ventricle as well. So what is the flow of the CSF? As we understand, CSF is mostly formed in the C-shaped lateral ventricle, but then from there it is poured into the midline ventricle, which is the third ventricle now. So here is the third ventricle, and once the lateral ventricle push the CSF into the third ventricle, how does it reach the fourth ventricle? By passing through the cerebral aqueduct of Sylvius in the midbrain. So midbrain is having a ventricle which is the cerebral aqueduct of Sylvius, connecting it with the fourth ventricle. The fourth ventricle is then sending the CSF into central canal towards the spinal cord. We have to understand that the fourth ventricle is sandwiched between two structures, brainstem anteriorly and the cerebellum posteriorly. Cerebellum is at the roof of the fourth ventricle, whereas at the floor of the fourth ventricle will have the pons and upper half of medulla oblongata. So as we can see, this is the fourth ventricle here, and fourth ventricle is sandwiched between pons at the floor along with upper half of the medulla oblongata, whereas the roof is the cerebellum. So that is the orientation of the ventricular system within the central nervous system. We'll talk about the CSF flow once again, but at this moment, let us look at some more structures which are becoming C-shaped. This diagram also is the lateral view of the developing brain, and here we can take the thalamus as the axis on which various structures are becoming C-shaped. We already have seen this largest part of the brain is the cerebrum, having a frontal lobe, occipital lobe, and the temporal lobe. And in the temporal lobe, we are having the hippocampus sending a C-shaped axons collection which is called as the fornix. The major output from the hippocampus is along with the choroid plexus, the capillary plexus, forming the CSF, which is also becoming C-shaped. And then caudate nucleus, part of the basal ganglia, is C-shaped, along with this corpus callosum. Now, we have to remember the first commissure to develop is the anterior commissure. This is the anterior commissure. Commissure fibers are connecting right side of the brain with the left side of the brain. For example, olfactory bulb of the two sides are connected by collection of axons, the anterior commissure, the first commissure to develop. The second commissure to develop is the C-shaped fornix. So as we are talking about fornix, it is again collection of axons and is connecting one-sided hippocampus, which is lying in the inferior temporal lobe as evident here. So the major output from the hippocampus is the fornix, and fornix is connecting one-sided hippocampus with the other sided hippocampus, some commissure fibers, some axons, and that fornix is the second commissure fiber to develop. The third commissure fiber to develop is corpus callosum, which is again C-shaped. So this corpus callosum, number 3 in sequence in this diagram to develop as commissure fiber, is connecting the right side of the brain with the left side of the brain, frontal to frontal, parietal to parietal, occipital to occipital, and temporal lobe with temporal lobe. Those collection of axons pass through the corpus callosum, which is again C-shaped structure. And what you can see is the head of the caudate nucleus, which is anterior, and then even the tail is coming anterior. This is the caudate nucleus, comma-shaped nucleus, part of the basal ganglia, again C-shaped, holding the thalamus in its grip. So thalamus is the axis on which the caudate nucleus, caudate plexus, fornix, corpus callosum all have become C-shaped, as was the cerebral hemisphere as well. We are going to revise the circulation of CSF once again. It is the sagittal view of the brain, and we have to understand that the choroid plexus, the capillary plexus, which forms the ultrafiltrate of blood, CSF is mostly present in the lateral ventricles, also in the third ventricle and the fourth ventricle. But most of the CSF is formed in the lateral ventricle. So as we are looking at the flow of the CSF from the lateral ventricle, it is reaching now foramen of Monro, which is interventricular foramen between lateral ventricle and the third ventricle. And from the foramen of Monro, now the CSF has entered hypothalamic sulcus in the third ventricle. So this is the third ventricle. And then it is running in the midline of the midbrain, that is in the cerebral aqueduct of Sylvius. From there, the CSF has to enter diamond-shaped ventricle, the fourth ventricle, which is now sandwiched between the pons and medulla anterior and cerebellum posterior. So this is the fourth ventricle. And from the fourth ventricle, it will enter the lower half of medulla oblongata, then further continuing into the spinal cord. So here is the central canal in the spinal cord. Now, not only the CSF is flowing downward, it is also escaping. From the roof of the fourth ventricle, there is a midline aperture, that is the Magendie foramen, and there are two lateral Luschka foramina. So as we have discussed earlier, the midline is MM, M for Magendie and M for midline, and L for L, lateral for the Luschka, which are 2 in number. And they are at the roof of the fourth ventricle. From there, the CSF is now escaping, coming into the subarachnoid space. And from the subarachnoid space, as is evident, it will be passing into the arachnoid villi and reaching the dural venous sinuses, like here, superior sagittal sinus. This is the subarachnoid space, and that is the arachnoid granulation. So, as we can find out that from the roof of the fourth ventricle to the Magendie and Luschka foramina, the CSF has come out into subarachnoid space, and then it is passing along with these arachnoid granulation into dural venous sinuses, like the superior sagittal sinus. Now, the dural venous sinuses, they are going to collect the venous blood into internal jugular vein. Internal jugular vein will carry the venous blood towards the heart, and the heart will push this deoxygenated blood towards the lung, which will then send the oxygenated blood to the heart. Heart will push it into the carotid system towards the brain, and then the choroid plexus. Hence, the circulation is completed. The choroid plexus is then again secreting the CSF in the lateral ventricle. From the lateral ventricle, CSF goes into the third ventricle, fourth ventricle, the foramen of Magendie and the Luschka, and again subarachnoid space, and then into the arachnoid granulation, dural venous sinus, and internal jugular vein, and the heart. So this flow is a continuous circle, goes on and on. CSF is nothing but ultrafiltrate of blood. And if you block this flow, there can be collection of CSF leading to hydrocephalus. Like the aqueduct stenosis, narrowing of aqueduct can result in internal hydrocephalus, or tuberculous meningitis, leptomeningitis. Blocking the CSF flow can result in external hydrocephalus, excessive accumulation of the CSF because you are blocking its flow. Let us look at the developing brain from the front view as well. We have taken a coronal section, and looking from the front view, we can see this is the choroid plexus, the capillary plexus, which is going to form the CSF mostly in the lateral ventricle, right and left. But some of the CSF is also projecting into the midline ventricle, which is the third ventricle. So this is the third ventricle, which is sandwiched between the thalamus and the hypothalamus. It is the ventricle of diencephalon. So as we can see, this third ventricle is having, in the upper part, it is the thalamus region, and in the lower part it is the hypothalamus region. And hypothalamus is not only forming the lateral wall of the third ventricle, but it is also at the floor of the third ventricle. Then we see there are some ascending and descending axons, the projection fibers. Later they will be contributing to the internal capsule, and this internal capsule is going to divide the corpus striatum into two parts. So this is the projection fiber or the internal capsule, which is dividing the corpus striatum, part of the basal ganglia, into two parts. So what are the two parts? We can remember L for L. Laterally is the lentiform part of the corpus striatum, and medially it is the C, the caudate nucleus, part of the basal ganglia. So what we are telling is this is the ascending descending fibers of the internal capsule, which is the projection fiber, dividing the corpus striatum into two parts, L for L. Laterally is the lentiform nucleus, and medially is the caudate nucleus. Lentiform nucleus itself will have the outer putamen and the inner globus pallidus, which are both part of the basal ganglia. Now on to discuss the details of this midline ventricle, third ventricle, as well as fourth ventricle in the next coming diagrams. Let us mark the third and the fourth ventricle in the sagittal section of the brain first. As you can understand, it is the lateral view, anterior-posterior sagittal section, where we can mention this part is the third ventricle, which will be pouring the CSF into the fourth ventricle. So let us demarcate the boundaries, starting from the foramen of Monro and reaching till the beginning of the aqueduct sylvius. This is the region of the third ventricle here. And in the third ventricle, in the lateral wall, we have this hypothalamic sulcus separating the thalamus above and hypothalamus below. So as we understand, starting from the interventricular foramen of Monro till the beginning of the aqueduct of Sylvius is the third ventricle, CSF flowing in the hypothalamic sulcus, which is separating thalamus above and hypothalamus below. The third ventricle is a midline ventricle sandwiched between the two thalami on either side, and we'll be magnifying this area, discussing more details. Then we have to talk about the fourth ventricle as well. We understand that fourth ventricle is a diamond-shaped ventricle and is sandwiched between the brainstem anteriorly and cerebellum posteriorly. So cerebellum is on the posterior side as the roof. At the floor is the pons and upper half of medulla oblongata. Sandwiched between is the fourth ventricle. It is lying between the ending of aqueduct sylvius and the beginning of the central canal. So as we can see, this is the ending of aqueduct sylvius, because this is the aqueduct sylvius in the midbrain, and this is the beginning of the central canal. So starting from the aqueduct sylvius and reaching the central canal, this is the territory of the fourth ventricle. Before we start talking about the detail of fourth ventricle, let us focus upon the third ventricle first. And we are going to magnify this part of the brain now. Once again, we can mark this is the interventricular foramen of Monro, which is basically connecting the lateral ventricles in the cerebrum with the third ventricle, which is the midline ventricle. CSF from the lateral ventricle will enter foramen Monro. To enter the third ventricle will be passing through this hypothalamic sulcus in the lateral wall of the third ventricle, reaching the beginning of cerebral aqueduct of Sylvius, which is actually in the midbrain. So this is the extent of the third ventricle. In the lateral wall, this hypothalamic sulcus is separating thalamus above, hypothalamus below. You can mark the thalamus here, the lateral wall, and hypothalamus below. And we have understood that the hypothalamus is not only forming the lateral wall of the third ventricle, but it is also forming the floor of the third ventricle. You can show some component of the hypothalamus forming the floor as well. So in the floor, this is the mammillary body, part of the hypothalamus, and anterior to that there will be a tuber cynarium, part of the hypothalamus. Now, what all structures are there at the floor of the third ventricle? Let us count them from anterior to the posterior aspect. Most anteriorly, we'll find there is the optic chiasma. So this is the optic chiasma at the floor of the third ventricle. Then we'll be having what is called infundibular stalk or the pituitary stalk, through which will be hanging the posterior pituitary supraspiratory or the neurohypophysis. So at the floor, most anteriorly is the optic chiasma, then we have the infundibular stalk or pituitary stalk hanging posterior pituitary. Behind that we have two components of hypothalamus, tuber cinereum, mammillary body, and still behind in the floor of the third ventricle we are having tegmentum, part of the midbrain here. So let us show the tegmentum part of the midbrain as well at the floor of the third ventricle. As we have seen, the third ventricle is having a floor, it will be having a roof also, and in the roof we have this C-shaped structure which is called as the fornix. So this is the fornix at the roof of third ventricle, along with what is called as the choroid plexus, the capillary plexus, which will be at the roof of the third ventricle, pouring some CSF into the third ventricle. So two structures at the roof, the fornix, collection of axons, and choroid plexus, a bunch of capillary plexus. Fornix is not only at the roof, but it is also extending to the anterior wall of the third ventricle. Then, as you will notice, passing anterior to the foramen of Monro, the fornix is coming on the anterior wall of the third ventricle as well. In the anterior wall, you have three structures, the fornix, and there is one anterior commissure, and then there is lamina terminalis. So, what are the three structures in the anterior wall of the third ventricle? Lamina terminalis, anterior commissure, and part of the fornix. The anterior commissure has commissure fibers connecting the right-sided olfactory bulb with the left-sided olfactory bulb and forming anterior wall of the third ventricle. And this is the lamina terminalis, which is actually the anterior end of the neural tube embryologically. Now, this is the anterior wall. What is there in the posterior wall of the third ventricle? You can remember PPP, and when you say in the posterior wall we have PPP, the first P is for the posterior wall of the third ventricle, the next P is the pineal gland here, and along with that there is a posterior commissure fiber connecting right side of the brain with the left side of brain. So on the posterior side we have the pineal gland and the posterior commissure as well, and you can bring the choroid plexus posteriorly here. As we have seen, choroid plexus is at the roof along with the fornix. The roof was having two structures, so there is a roof, there is a floor, there is anterior wall and posterior wall of the third ventricle. Midline ventricle sandwiched between the two thalami and hypothalami. The hypothalamus forming the floor as well. Here we continue talking about the ventricular system to have an orientation, and looking from the front view, first it is the intact brain, and then we have taken one coronal section right to left so as to look inside the ventricular system. Now, as it is understood, the largest of ventricles, which are C-shaped ventricles, are the lateral ventricles, which you can mark here. One is on the right side here and one is on the left side, and then these lateral ventricles can be seen even in the cut section here. So these are the lateral ventricles, one on the right side, one on the left side. As is evident, these ventricles are having a roof of the corpus callosum. So these are the lateral ventricles having a roof of the corpus callosum connecting the right brain with the left brain, the commissure fibers, and the two lateral ventricles are separated by what is called as septum pellucidum. So septum pellucidum is the septum which is separating the two lateral ventricles. You can also see one fornix on each side. Fornix will be the collection of axons, one on either side, and they are attaching to the septum pellucidum inferiorly. In fact, the fornix is the roof of the third ventricle as we have discussed earlier. So this is the midline ventricle, which is the third ventricle. You can mark it here, and this third ventricle can also be seen on the other sided brain here, the midline ventricle. So how do you connect the third ventricle with the lateral ventricle? Through interventricular foramen of Monro, which you can see here. So as you are marking them here, these are the interventricular foramen of Monro in this diagram and the other diagram as well. So as we are showing them here, lateral ventricle pouring CSF into midline third ventricle. The same thing here, lateral ventricle pouring the CSF into third ventricle. Third ventricle is sandwiched in thalamus and the hypothalamus, which you can mark them here, mentioning this is the region of diencephalon. Upper is thalamus, below hypothalamus on right side, and this is thalamus, hypothalamus on the left side. And they are sandwiching the third ventricle. Then comes the cerebral aqueduct of Sylvius in the midbrain, and then the diamond-shaped fourth ventricle in the hindbrain. So as we are marking, this will be the cerebral aqueduct of Sylvius in the midbrain, as can be seen here, continuing into the diamond-shaped ventricle, the fourth ventricle on either of the diagram. Now this fourth ventricle, as is understood, is sandwiched between cerebellum on the posterior side, whereas brainstem on the anterior side. In the brainstem also, entire pons and upper half of medulla oblongata, because in the lower half of medulla oblongata we are going to have what is called as the central canal. And this central canal then is continuing into the spinal cord inferiorly. So here is the central canal in the cut section, continuing inferiorly into the spinal cord. Now what we need to do is we will be looking at the fourth ventricle, but from the posterior view. After removing the cerebellum, we have to look at the floor of the fourth ventricle. But how do you remove the cerebellum? The cerebellum will have three peduncles connecting to the brainstem. If the cerebellum is connecting to the midbrain, it is superior cerebellar peduncle. To the pons, it is middle cerebellar peduncle. To the medulla, it is inferior cerebellar peduncle. So cut the three peduncles, remove the cerebellum, and look at the floor of fourth ventricle, a diamond-shaped ventricle, from posterior view in the next diagram. And as is evident, we are looking from the posterior view here. We have removed the cerebellum so that we can look at the floor of the fourth ventricle, the diamond-shaped ventricle. And how do we remove the cerebellum? By cutting the peduncles. Like you see, this is the superior cerebellar peduncle on the either side, and then you can mention it is connecting the cerebellum to the midbrain. You can also see the middle cerebellar peduncle on the either side, and they are connecting the cerebellum to the pons. We have cut them as well. Then we have got the inferior cerebellar peduncle on either side, connecting the cerebellum to the medulla oblongata. And only after cutting these peduncles, we have removed the cerebellum, which was at the roof of the fourth ventricle. Once you remove the cerebellum, you can see the floor of the fourth ventricle, the diamond-shaped ventricle, which you can demarcate here. This is the diamond-shaped fourth ventricle now. And we are finding that at the floor of the fourth ventricle, we have the dorsum of the pons entirely and dorsum of the upper half of medulla oblongata. Because in the lower half of medulla oblongata, we have the central canal. It is only in the upper half of medulla oblongata we have the fourth ventricle. Then there will be a pontomedullary junction as well. Let us demarcate that here and mention just above this pontomedullary junction, we can see what is called as stria terminalis. These are some elevations produced by the axons coming from anterior to posterior pons. So these are the stria terminalis on the dorsum of the lower pons. In the lower pons, we can also see rounded elevation called as the facial colliculus, produced by the axons of the facial nerve passing deep to that. So here we have got the rounded elevation called as the facial colliculus produced by the axons of the facial nerve. If there is a lesion here, then the muscles of the facial expression can be compromised. A question came like, rhizorius muscle of facial expression will be compromised. But remember, if the lesion is deeper, then a nucleus which is deep to that is abducent nucleus will be compromised, then paralyzing the lateral rectus muscle, because lateral rectus is supplied by sixth nerve, the abducent nerve, which lies deep to facial colliculus at the floor of the fourth ventricle. Now, at the floor of fourth ventricle, on the dorsum of the upper pons, we have the locus ceruleus. This locus ceruleus will appear darker in color because of the neuromelanin it is having. Now, this was regarding the upper pons and lower pons. Let us focus upon the upper half of medulla oblongata as well. At the floor of the fourth ventricle, it is the dorsum of the medulla oblongata. Near the midline, we have the 12th nerve nucleus and producing a triangle-like structure on either side, and we are calling it as hypoglossal triangle. Cranial number 12 near the midline. Then 12th nerve is near the midline, 10th nucleus is lateral, and 8th nucleus is most lateral. So you can remember the sequence 8, 10, and 12. The hypoglossal triangle is near the midline, and vagal triangle is more lateral, which you can see here now. More laterally, we are having the vagal triangle. Cranial nerve number 10 on either side. Let us put a different color here, the yellow color. And if we go still more lateral, the most lateral is the 8th nerve, the vestibulocochlear nerve. What is shown here is the vestibular area, so cranial nerve number 8. What we can understand is if there is a lateral medullary ischemia, Wallenberg syndrome, then the 8th nerve is involved and the patient will be having vertigo. And if it is medial medullary syndrome near the midline, then the 12th nerve will be involved and there will be paralysis of the tongue muscle on the affected side, ipsilaterally. So these are all the details at the floor of the fourth ventricle. As we understand, the thalamus and hypothalamus, they belong to diencephalon part of the brain, and we have understood that there is a third ventricle in the midline which is sandwiched between the thalamus and the hypothalamus. Hypothalamus not only form the lateral wall or the third ventricle, but it is also the floor of the third ventricle. Let us look at one diagram to describe the location of the two, and this is looking from the lateral view. As we take one sagittal section, it is understood in the lateral wall of the third ventricle, if if it is the higher portion, there we will have the thalamus having several nuclei, and in the lower portion, the hypothalamus itself having several nuclei, not only forming the lateral wall but also the floor of the third ventricle. But first, let us look at the thalamic nuclei. Thalamus is basically one relay center, and this relay center, as we are looking from the lateral view once again, is going to connect the higher brain center with the lower brain center. For example, there are some sensations coming from the face, from the body. It will be reaching the thalamus, and then it is relaying it to the higher brain center, the cerebrum. Now, the brain will be sending pathways. They also have to pass through the thalamus. Now, as we have magnified the thalamus, this is the anterior portion, posterior portion. There are some nuclei. Let us begin from the anterior nuclei. As you see, it is a midline where both the thalami are shown. So one anterior nucleus on either side. This anterior nucleus is actually a part of the Papez circuit. And what is this Papez circuit about? It is a part of the limbic system. And what is limbic system about? Limbic system is about the memory, the emotions, the behavior of an individual. So there we have a Papez circuit, and what we understand is this anterior nucleus of the thalamus is going to receive a mammillothalamic tract coming from the mammillary body of the hypothalamus, and it is a component of the Papez circuit. So basically, when we are talking about the anterior nucleus of the thalamus, it is receiving input from the mammillary body, the mammillothalamic tract, and if we compromise it, there'll be a problem with the Papez circuit, problem with the limbic system, and the consolidation of memory, emotion will be compromised. There can be a problem in recall of the memory. We'll be discussing it further when we look at the hypothalamus, because that is where we will describe the mammillary bodies as well. Now, this is about the anterior nucleus of thalamus. What about the posteriorly placed nuclei? There we have the metathalamus having two geniculate bodies. Laterally, the lateral geniculate body for light pathway, and medially, the medial geniculate body for music pathway. You can remember the lateral geniculate body and the medial geniculate body, they are the metathalamus. And M for M, medial geniculate body is for music or auditory pathway, and L for L, lateral geniculate body is for the light pathway. So as it is understood, in the posterior group, we are finding a lateral geniculate body. The light pathway is the relay center towards the occipital visual cortex, area number 17, broadband number. The pathway which we are talking about is from the lateral geniculate body. There will be a geniculocalcarine tract coming from the geniculate body towards the calcarine cortex, area number 17 on the occipital cortex, whereas the medial geniculate body for music, it will be going to the temporal auditory cortex, area number 44-45. So as you see here, it is the temporal lobe, area number 44-45, and it is the auditory pathway from the medial geniculate body. So this is about the posterior group or metathalamus. Then we'll see there is a ventral group also, and in the ventral group, we can remember two components, the VPL and VPM. So what is this VPL and VPM doing? This VPM, ventroposteromedial, and VPL, ventroposterolateral nuclei are basically to receive sensations. And with sensations, it could be the touch, pain, temperature, pressure, vibration. For example, this is the face and this is the body. Now, for the face, trigeminal nerve is working and it will be carrying sensation to the VPM. So, as we are talking about this ventral group of thalamic nuclei, they are receiving some sensations like touch, pain, temperature, pressure, vibration. If it is the sensation from the face, the trigeminal nerve brings the sensation here and towards the VPM, ventroposteromedial nucleus. But if we are talking about touch, pain, temperature, pressure, vibration, upper limb, lower limb, then it will be the tracts like spinothalamic tract or dorsal column, and the sensation will be then reaching the VPL, ventroposterolateral nucleus of the thalamus. So for the upper limb, lower limb, and the body, the tracts are dorsal column and spinothalamic tract. They bring touch, pain, temperature sensation towards the VPL nucleus. The VPM is for the upper body, that is the face, trigeminal nerve, and VPL is for the lower body, upper limb, lower limb, receiving sensations via the dorsal column, spinothalamic tract. Now, once the sensations have reached the thalamus, let us zoom this area, we will find that the thalamus is going to project it to the cerebrum, the sensory part of cerebrum, which is called as postcentral gyrus, broadband area number 1 to 3. Right parietal sensory cortex. As we have mentioned, thalamus is like a relay center. Now, what we are left with is near the midline, the medial nucleus, and then there's a lateral nucleus. Now, may it be the medial nucleus or lateral nucleus, both of them are related to emotions projecting to the prefrontal cortex, as is evident here, medial group, emotions to the prefrontal cortex. And when you are talking about slightly lateral, this is the lateral group. You see it is also for emotions, but this time it is projecting to the somatosensory cortex, parietal sensory cortex. So you can mark them here, the medial, as is evident here. This is the medial near the midline for the emotions, and to the prefrontal cortex. Prefrontal cortex, which is related with our personality, social interaction. And this is the lateral group. As you can see, lateral group is also related with the emotion, but this is projecting to somatosensory cortex, also presenting in the parietal sensory cortex in the cerebrum. And now let us talk more about the Pappage circuit, which is related with the anterior thalamic nucleus, with the limbic system and the mammillary body. So here again, looking from the lateral view, occipital section, we already have talked about the thalamic nuclei. Now we are coming below thalamus, that is hypothalamus. Hypothalamus, which is forming the lateral wall and floor of the third ventricle. And that is where we were talking about the mammillary body, projecting to the anterior nucleus of thalamus, mammillothalamic tract. So this mammillary body itself is receiving the input from where? The mammillary body, part of the hypothalamus, is actually receiving information from the hippocampus via the fornix. Hippocampus, which is present in the temporal lobe, is having one major output, and that is via the fornix. So mammillary body is receiving the efferent, that is the incoming fibers, from the hippocampus. And it is a part of the Pappage circuit. Pappage circuit relates with the limbic system, as we were talking about, and limbic system relates with the memory, emotions, behavior of an individual. So limbic system, Pappage circuit, if it is related with the memory, it is related with the short-term memory first, and then you want consolidation of memory. And that is why hippocampus sends the information via the fornix, which is sent towards the mammillary body. If there is a problem with the fornix, then there will be a problem with the recall of the memory, especially the recent memory. Pappage circuit gets compromised. Now, from the mammillary body, where the pathway is going? It is mammillothalamic tract, again a part of the Pappage circuit towards the anterior nucleus of thalamus. So it is reaching the anterior nucleus of the thalamus. What will happen if there are some hemorrhagic lesion in the mammillary body, like in chronic alcoholism or in some other pathology? What happens in Wernicke's encephalopathy? In Wernicke's encephalopathy, when there is a compromised mammillary bodies, patient will present with anterograde amnesia, confabulation. There will be a problem in recall of the recent memory, and he will cook up some stories to fill in the gaps in the memory. Anterograde amnesia is a feature of Wernicke's encephalopathy, a problem of mammillary body in the hypothalamus. Now, in the hypothalamus also you have anterior nucleus and posterior nucleus. This anterior nucleus of the hypothalamus is for dissipation of the heat, activating the parasympathetic autonomic nervous system. And to antagonize that, there will be a posterior nucleus. So there is one anterior nucleus, as you see, and then to antagonize that, there will be a posterior nucleus. Now, what is this posterior nucleus doing? As you say, it is going to activate the other part of the autonomic nervous system, which is sympathetic nervous system. You know, sympathetic nervous system is causing vasoconstriction in the periphery. So conservation of heat, that is the purpose, thermoregulation and conservation of heat. It is understood that the posterior nucleus of the hypothalamus, which is under the sympathetic system for vasoconstriction, is going to antagonize the anterior nucleus, which is for dissipation of heat under the parasympathetic system. Now, similarly, we have a medial and lateral nucleus. When you are talking about the medial nucleus, remember VMS, ventromedial satiety center. As you are having food and you are satisfied, this center will be activated. So, ventromedial satiety center, after having good amount of food, you will have the satiety. And exactly opposite, you have got a lateral nucleus. And obviously, lateral nucleus will be the nucleus for hunger. So, here is the lateral nucleus and it is stimulating the eating. There was one experiment done where the scientists have damaged the lateral nucleus in a cat, and the cat never felt like eating. So, it became very thin and it was actually starving. On the other hand, the other cat, there was a lesion in the VMS, ventral medial satiety center, center. And the cat was never satisfied. It became very obese. So destruction of the ventromedial satiety center will result in obesity. Now, one other set of nuclei is to be discussed, paraventricular and supraoptic. Like we have discussed, there is optic chiasma at the floor of the third ventricle and supraoptic nucleus plus paraventricular nucleus. They are the one which are going to give us hormones like oxytocin and antidiuretic hormone. And when you are talking about these hormones, you can understand the antidiuretic hormone is working at the level of collecting ducts for the reabsorption of the water while formation of urine. So if you want to conserve the water, it is a function of the collecting duct under ADH. And obviously, if there's a problem with ADH, conditions like diabetes insipidus can happen. On the other hand, if you're talking about oxytocin, oxytocin is the hormone which works for the contraction of the uterus for the delivery of the baby. And once the baby is delivered, baby want to feed, so suckling reflex will help in bringing milk to the mammary gland. So that is the function of the oxytocin. Uterine contraction, suckling reflex, milk ejection under the paraventricular and supraoptic nuclei of the hypothalamus. As we talk about the homunculus, it could be sensory or motor homunculus. It is basically the representation of the human body but upside down on the cerebral cortex. Let us make use of a diagram to understand the same. We are looking from the superior view. One person is lying here. The head is towards us. These are the shoulders, the arm, the body, and the lower limbs are away from us. Basically, to understand that we are looking from the superior view of the cerebrum here. This is the midline, that is anterior, and this is posterior. So obviously on the anterior side we'll be having the frontal cortex. So anteriorly this will be the frontal lobe or frontal cortex, and posteriorly this will be the parietal cortex, parietal lobe or parietal cortex. The same can be mentioned here on the front. We will be having the frontal lobe, this area, and on the posterior side there will be parietal lobe, the parietal area. Now once we have mentioned that, we should understand there is going to be one central sulcus on the cerebrum, which is running antero-inferiorly, separating frontal lobe on the front and parietal lobe posteriorly. The same thing you can show there as well. This is the central sulcus running antero-inferiorly on the cerebrum, and it is going to separate the front, the frontal lobe, and posterior, the parietal lobe. Now, just anterior to that, you have pre-central gyrus, and behind that is post-central gyrus. And as we mentioned that, this pre-central gyrus is the frontal motor cortex, and the neurons in this area, if they are activated, they'll be controlling certain parts of the body. But the body is represented upside down in a homunculus fashion, which we are going to discuss. In the same way, if we are looking at the post-central gyrus, it is the parietal sensory cortex, and if any part of the body is receiving sensation like touch, pain, temperature, pressure, then this part of the cerebral cortex will be activated. We can mention that anteriorly it is the frontal motor cortex, precentral gyrus, and posteriorly it is the postcentral gyrus or parietal sensory cortex, but represented in a homunculus pattern. So what is that homunculus pattern? As we are telling, it could be sensory motor homunculus but upside down. So this is the head area, upper limb area, body, and the lower limb area. And what we need to understand is, if you are touching on the face or moving some muscles on the face, then this part of the cerebrum will be activated. So let us represent this body upside down here. The face area is on the lower part of the cerebrum, and as we draw it here, this area represents the head. Then you have the neck, the upper limb, the body, and you cannot represent the lower limb here. Only till pelvis perineum it is represented here. The lower limbs are actually dipping down in this part of the cerebrum, on the medial part of the cerebrum, what is called as paracentral gyrus. So my point is, if this part of the cortex is activated, some muscles in the face will be moving. If this part of the cortex is activated, some muscles in the upper limb will be moving. And if this part of the cortex is activated, then some pelvis perineum muscles will be activating. If you want to activate the lower limb muscles, then you have to go medial and then activate the area. On the other hand, if you are touching the lower limb, then sensation will be received in the post-central homunculus, but on the medial side. And if you are touching the upper limb, then this part of the cerebrum, post-central gyrus, will be activated. And if you touch the face, then still lower. It can be better understood in the next diagram now, where we are looking from the front view. We have taken a coronal section and looking on the right half of the cerebrum and representing the body in homunculus again. Now, may it be motor homunculus or sensory homunculus, the representation of the body is upside down. If you are touching the face, this part of the cerebrum will be activated. But if you are touching the upper limb, then slightly higher. This is the area for the upper limb. And if you are talking about the pelvis perineum region, still higher. And if we focus upon the lower limb, then it is on the medial part of the cerebrum, paracentral gyrus. So representation of the human body in upside down fashion is called as homunculus, maybe sensory or motor. Now, the importance of knowing about this is there is one anterior cerebral artery supplying this area. So if anterior cerebral artery is compromised on the medial cerebrum, there will be motor sensory loss on the lower limb and pelvis perineum region. Whereas on the lateral cerebrum, there is arterial supply by middle cerebral artery. If middle cerebral artery is compromised, then there will be motor sensory problem on the face. And if branches are compromised here on the upper limb. So that is the importance of knowing about the representation of human body in a homunculus pattern. Discussing about the Brodmann numbers, the various functional areas on the cerebrum, let us have a look over the diagram. And looking from the lateral view, we can see there are some numbers given for the functional areas. First, we will be talking about the central sulcus we have discussed, which is running anterior-inferiorly and separating the frontal lobe on the front and parietal lobe posteriorly. So as we are marking the central sulcus here, running anterior-inferiorly, we have discussed earlier, there will be a precentral gyrus, which will be having frontal motor cortex and which is controlling skeletal muscles of the body, but represented in homunculus as we have understood. The lower area for the face, then we have the upper limb area, then we have the abdomen pelvis perineum area. For the lower limb, we have to go to the paracentral lobule on the medial side of cerebrum. Now, this is the area which, if compromised, say middle cerebral artery is having a thrombosis, then there will be hemiparalysis on the face. If it is somewhat upper area compromised, then it will be hemiparalysis on the upper limb, or here it will be the pelvis perineum, like that in homunculus pattern. Now, this is area number 4, that is precentral gyrus. What about the postcentral gyrus or parietal sensory cortex? The postcentral gyrus or parietal sensory cortex is area number 1 to 3, and a lesion of area number 1 to 3 parietal sensory cortex is a problem of journal sensations, like there is problem of touch, pain, temperature, pressure, vibration, again in the homunculus pattern. If it is lower area, facial involved. If it is upper area, the upper limb is compromised, or maybe the abdomen region, pelvis perineum region. Body represented upside down, sensory homunculus, postcentral gyrus. But as we know, it will be always contralateral problem because the cerebrum has contralateral representation. If there is a lesion on the right side of cerebrum, the problems will appear on the left side of the body. Now, this is area number 1 to 3 and 4. We can talk about area number 17, occipital visual cortex, and that is the area which, if compromised, there will be visual problems like hemianopsia. So area number 17, occipital visual cortex, lesion can result in hemianopsia. That is for the vision. What about the hearing? Deep to the temporal lobe, we have area number 41-42, temporal auditory cortex, superior temporal gyrus. Any lesion here and will have problem of hearing. If you go to the superior temporal gyrus, more posteriorly, there is a Wernicke's sensory speech area. So superior temporal gyrus, more posteriorly area number 22, that is Wernicke's sensory speech area. This is for comprehension or understanding of language. If any lesion here, there will be Wernicke's aphasia. Patient cannot understand the spoken language or the written language. Problem of comprehension of the language. And you double the number 22 into 244. That is the Broca's motor speech area in the inferior frontal gyrus. So this is area number number 44, 45, that is the Broca's motor speech area in the inferior frontal gyrus. If it is compromised, there will be a problem in planning of the muscles of the speech. So the speech becomes difficult. Hesitant speech, that is the problem. It is expressive aphasia. We can also look at area number 8 here, which is frontal eye field, and this is the one which is helping us to coordinate the lateral rectus of one eye and medial rectus of other eye for horizontal gaze movement. So frontal eye field, that is the middle frontal gyrus. If any lesion occurs here, there will be a problem of horizontal gaze. Cranial nerves. If we are talking about the cranial number 1 and 2, they belong to the forebrain, whereas the number 3 to 12 will be coming from the brainstem. Cranial number 1 is the nerve of telencephalon for smell pathway, and cranial number 2 is the optic nerve for visual pathway. Let us look at a diagram which will be showing us some of the cranial nerves related to the brain. And here we are looking from the inferior view. This is the patient whom we are putting into this CT scan machine. The head is away from us and the feet are towards us. Basically, it is to orient ourselves that we are looking from inferior view of the brain, the base of the brain. So it will appear like this. Let us zoom this area. This is the actual dissected specimen and this is the schematic diagram. And we'll be discussing them side by side. So as we zoom this diagram, talking about the base of the brain, you can start with cranial number 1, which is going to terminate here. And this is the olfactory pathway. So CN1, cranial number 1 pathway for smell. It is the nerve of telencephalon. Can also be shown on this side of the diagram, the actual dissected brain here. So here is the cranial number 1 for smell pathway, and it is shown on the other side as well, nerve of telencephalon. Now what about the nerve of diencephalon, the optic nerve? So it is cranial number 2, and this is coming from the retina of the eyeball. The nerve of the diencephalon can be seen in the actual brain as well. So this is the nerve number 2, or the optic nerve, coming from the retina of the eyeball, the nerve of the diencephalon. Now, number 3 to 12 will be coming from the brainstem, which will be the midbrain, pons, and medulla oblongata. Now, number 3 and 4 will be coming from the midbrain. As you see here, this is the number 3 coming from upper midbrain, and this is the number 4 trochlear nerve coming from the lower midbrain. And we have to understand that the trochlear nerve is the only cranial nerve which is coming to the dorsal side. Later, it's come ventral and then supply the muscle called as superior oblique. So here, as we focus upon the nerve number 3 coming from upper midbrain, and number 4 coming from lower midbrain, you can represent them here as well, as we are focusing upon. Now number 3, it is seen here on either side, whereas the number 4 is very thin and is evident here. In fact, it is the thinnest cranial nerve, the trochlear nerve, because it has very few axons. Then which is the thickest cranial nerve? Thickest cranial nerve is the trigeminal nerve. The name is telling it is 3 nerves into 1, bringing a lot of axons. That is why it is thickest cranial nerve, and it is arising from the pons. As you represent it here, this is the trigeminal nerve coming from the pons, the thickest cranial nerve, and it is understood. The thickest cranial nerve is very close to the thinnest cranial nerve, the trochlear nerve. So as we see, this is 5th nerve, this is the 4th nerve, the thinnest and the thickest nerve, and they are lying close to each other. From the pons comes the trigeminal, thickest cranial nerve, largest cranial nerve, and this is the number 4, the trochlear nerve, thinnest, slimmest, smallest cranial nerve in terms of size. Then what about the nerve number 6? The number 6, though the nucleus is in the pons, it is coming at the pontomedullary junction. So here is the abducens nerve coming at the pontomedullary junction. As you can see, this upper area is the pons looking like a bridge, and this is medulla oblongata. So here, pontomedullary junction, most medial nerve is abducens nerve. You can show that here as well. The most medial nerve, the abducens nerve, near the midline, because then we have the number 7, 8 also coming at the pontomedullary junction. So now number 6, 7, and 8 medial to lateral. They exit at the level of pontomedullary junction. As you will show, this is abducens nerve. This is the facial nerve on either side, and then the vestibulocochlear for hearing and balance on either side. This is vestibulocochlear, the facial. So as you see, facial nerve a bit lateral, and vestibulocochlear is the most lateral at the pontomedullary junction. Now, once we have described the number 6, 7, and 8 at the pontomedullary junction. What about the number 9, 10, 11? Number 9, 10, 11 will be coming from the medulla oblongata behind a rounded elevation called olive. You can start discussing it here, then more clearly can be seen there. So as you are talking about the number 9, this is the number 9, glossopharyngeal nerve. Then inferior to that is the number 10, the vagus nerve, and there will be one accessory cranial part 11 coming from medulla oblongata. So cranial accessory nerve can be seen here. Now the same thing you can show here in the schematic diagram. Now number 9, the glossopharyngeal, now number 10, the vagus nerve, and cranial accessory nerve is seen here. As is evident, now number 9 to 11, they are coming from the medulla oblongata but behind posterolateral to this rounded elevation, which is called as the olive. On the medulla oblongata, there's a midline structure on either side, the pyramid, and posterolateral to that are rounded structures, the olive, and posterolateral to that is the number 9, 10, 11. Let us show them bilaterally here behind the olive, or posterolateral to olive, the number 9 and 10 and cranial part of 11. So if this is the number 9, 10 and cranial accessory, what is this rounded structure? That is the olive. And what is this structure near the midline? That is the pyramid. And what is between pyramid and olive? This nerve rootlet. The last cranial nerve here, the number 12 on either side. This is the 12th nerve, the hypoglossal nerve controlling the tongue muscles. So as you are showing it, this is the 12th nerve, hypoglossal nerve, and it is sandwiched between pyramid anterior on the medulla oblongata and olive posterior. So this is the pyramid anterior, olive posterior, and sandwiched between the two is the 12th nerve. Can also be shown here, though it is actually overlapped by the vertebral arteries forming the basilar artery and then posterior cerebral artery, the circle of village contribution. But our focus is not on the arteries here. So let us just focus upon hypoglossal nerve. And as you are talking about the hypoglossal nerve, which control the tongue muscle, is coming from medulla oblongata, the most medial nerve. And that is why if it is medial medullary syndrome, the 12th nerve is compromised, tongue muscle paralyzed. And if it is lateral medullary syndrome, the number 9, 10, 11 compromised, and difficulty speech and swallowing. Now, once we have represented these cranial nerves on the base of the brain, they are going to exit through the cranial cavity foramina, and we have to look upon them now. Let us look at the floor of the cranial cavity and the various foramina through which the cranial nerves will be passing. And this is the same orientation we are looking from the superior view of the cranial cavity after removing the skull cap, the brain. We are looking at the floor of the cranial fossa, anterior cranial fossa and the middle cranial fossa and the posterior cranial fossa. There are some foramina to let pass the cranial nerves which we have just seen coming out from the brain. So let us look at this diagram and zoom the region of the anterior cranial fossa so as to discuss the cranial nerve number 1, which is coming from the roof of the nasal cavity. So from the roof of nasal cavity, the nerve number 1 will come and will be passing cribriform plate of ethmoid bone, which you can see here. Let us zoom this area now, showing multiple openings in the cribriform plate of ethmoid bone for the passage of the cranial nerve number 1 axon on one side here and the other side as well. So this is cranial nerve number 1. What about cranial nerve number 2? It will be actually coming from the eyeball in the orbit and passing through the optic canal. And this optic canal, which let pass the cranial number 2, is actually an opening in the lesser wing of the sphenoid. Let us show the lesser wing of sphenoid here, which is at the roof of the orbit. So the number 1 is coming from the roof of nasal cavity, reaching the brain, which was removed from here. And then this is the cranial number 2 optic nerve. What about the number 3, 4, and 6, which are supplying the muscles of the eyeball? They have to pass through the superior orbital fissure, a gap which is between the anterior cranial fossa and middle cranial fossa, or you can say a gap which is between the lesser wing of sphenoid and greater wing of sphenoid. So let us mark the superior orbital fissure on either side. This is the superior orbital fissure, not clearly seen but is evident on either side, is a gap between lesser wing of sphenoid, which we have shown here, and greater wing of sphenoid, which is here. And in the greater wing of sphenoid, we are seeing some of the opening like foramen rotundum, foramen ovale, and foramen spinosum as you mark. Foramen rotundum, foramen ovale, and foramen spinosum are the openings in the greater wing of the sphenoid here. Now, medial to foramen ovale, we find a lacerated foramen, foramen lacerum. As you can see, it is evident on either side. So let us mark it. This is the foramen lacerum on either side, and you are marking it there. You can also mention about the sphenoid bone then. This is the body of sphenoid having the pituitary fossa called as sella turcica in the midline to keep the pituitary. So body of the sphenoid at the floor of middle cranial fossa having pituitary fossa to keep the pituitary gland. Body of sphenoid is also going at the floor of anterior cranial fossa, and it is also reaching the floor of posterior cranial fossa. So this is the body of the sphenoid. Sphenoid is like a butterfly having a body, a lesser wing and a greater wing on either side. So lesser wing, greater wing, and the body. Now where is the number 3, 4, 6 supplying the muscles of eyeball passing? They are passing through superior orbital fissure, gap between anterior cranial fossa, middle cranial fossa, or you can say it is a gap between the lesser wing of sphenoid at the floor of anterior cranial fossa and greater wing of sphenoid at the floor of middle cranial fossa. Then where is the number 5 passing? The number 5 is trigeminal. It will have 3 branches, and if you are talking about 5-1 ophthalmic division of trigeminal, its branches will be passing through superior orbital fissure. And what about the 5-2, the maxillary nerve? Maxillary nerve, which has to supply the maxilla bone, will be passing through foramen rotundum. And what about the 5-3, the mandibular nerve? Mandibular nerve supply the bone mandible, and it is passing through the foramen ovale in the greater wing of sphenoid. So we have seen the number 1, the number 2, the number 3, 4, 6, and 5. What about the number 7 and 8? For discussing the number 7, 8, we have to go to the posterior cranial fossa and talk about the internal auditory meatus. The number 7, 8 will be passing here in the temporal bone. The number 9, 10, 11 passing through the jugular foramen, which is a gap between temporal bone and occipital bone. And in the occipital bone, there is hypoglossal canal, which you can see here for the passage of the 12th nerve, last cranial nerve. And then we can see a large foramen, the foramen magnum. And once we have described the various cranial foramina, we can look at the cranial nerves also exiting through them in the next diagram, which is once again the superior view of the cranial cavity after removing skull cap and the brain. This time we are talking about cranial nerves exiting various cranial foramina, and the nerves themselves are evident. So superior view, and you can see once again zooming at the roof of the nasal cavity piercing the cribriform plate of ethmoid bone is the cranial number 1 for the smell pathway on either side of the midline. Now if this is the number 1, this is the number 2, the optic nerve. As we have told, it is the nerve for vision coming from the retina in the eyeball. So the number 2 passing in the optic canal, whereas the number 3, 4, 6 will be passing first in the cavernous sinus, lateral to the pituitary gland, and then this number 3, 4, 6 will be passing superior orbital fissure, the gap between anterior cranial fossa and middle cranial fossa, to reach the orbit and supply muscles of eyeball. So where is the number 3? As we are talking about the number 3, it is here. This is the number 6, and then this is the number 4. So as we mark, this is the number 3, the number 6, and the number 4. We'll find out how do we identify them individually. But these are the nerves which are supplying the eyeball muscles coming from the brain stem. Then they become a content of cavernous sinus, and then superior orbital fissure, and then orbit to supply the muscles of eyeball. We have to understand that the number 3 is most medial in this relation, and the number 4 is most lateral. The number 6 is lying in between the two. So once again we can mention this is the number 3, this is the number 4, and this is the number 6. But how do you identify them? See, we have to remember the number 3 is close to the number 2, the optic nerve. So this is optic nerve, and this is the oculomotor nerve. As you can see, the number 2 and the number 3, they are close to each other. But then when you search for the number 4, it is close to the number 5, trigeminal nerve. So thickest cranial nerve is trigeminal nerve, thinnest cranial nerve is trochlear nerve, and they are close to each other. So you are telling that this is the number 5 here, the trigeminal. Yes, you can see it is giving 3 branches, 5-1 and 5-2 and 5-3 as well. 5-1 is ophthalmic nerve, branch of trigeminal. 5-2 is maxillary nerve. 5-3 is mandibular nerve, branch of trigeminal nerve. Now once you mention it like that, the other thing which we are mentioning is the number 5, the thickest cranial nerve, is close to the number 4, the thinnest cranial nerve. Then where is the number 6? The number 6 is here. This is the number 6 and is identified by the fact that the number 6 will be piercing the dura mater in the posterior cranial cranial fossa running in Dorello's canal, and then it will become a content of the cavernous sinus before it becomes a content of the superior orbital fissure. So once again, you can mention the number 2, close to that is the number 3. Then is the number 6. If you want to look for the number 4, it is close to number 5. Thinnest cranial nerve, trochlear, thickest cranial nerve, trigeminal. Now, talking about the trigeminal nerve, we will see that it is having phi 1 ophthalmic division of trigeminal, phi 2 the maxillary nerve. Both of them become content of cavernous sinus, but not the phi 3 mandibular nerve. Mandibular nerve is not a content of cavernous sinus. It is just passing through foramen ovale and going to supply the bone mandible. Whereas phi 2, that is the maxillary nerve, is a content of cavernous sinus, going to supply the maxillar bone, but first it has to pass foramen rotundum. Whereas phi 1 ophthalmic nerve will be giving some branches after passing through cavernous sinus. Those branches will be passing superior orbital fissure along with the number 3, 4, 6. So here we have seen the number 1, 2, 3, and then 4, 5, and then 6. What about the number 7 and 8? To discuss the number 7, 8, we have to come to the posterior cranial fossa. And as we do that, we see the number 7, 8 are passing through the internal auditory meatus in the temporal bone, but in the posterior cranial fossa. So that is the number 7 and 8. What about the number 9, 10, 11? The number 9, 10, 11, they are passing through the jugular foramen. And when we are talking about the number 12, then it will be seen passing the hypoglossal canal in the occipital bone. So hypoglossal nerve supplying the tongue muscle is passing hypoglossal canal. We can also see the foramen magnum here, and deep to the foramen magnum in the vertebral canal we can see the spinal cord. So spinal cord is not in the foramen magnum, it is actually inferior to that in the vertebral canal. From the spinal cord is coming spinal accessory nerve, which will be meeting cranial accessory nerve. So spinal accessory nerve is entering the cranial cavity passing foramen magnum and exiting the cranial cavity passing the jugular foramen. And this spinal accessory nerve staying for a short duration inside the cranial cavity is a nerve which is going to supply the sternomastoid and trapezius muscle after passing the jugular foramen. This is called a spinal accessory nerve, which will meet with the cranial accessory nerve. Along with that, number 9 and 10 are also passing jugular foramen. This is the same diagram which we have seen, and in fact it is one cadaveric dissection where we have taken the skull cap, the brain, and then we are looking at the floor of the cranial cavity showing the anterior cranial fossa floor and middle and posterior cranial fossa floor. Various foramina and through which the cranial nerves are exiting. As you understand, at the roof of the nasal cavity there will be cribriform plate of ethmoid bone and several axons will be coming out through that. This is going to be the cranial nerve number 1. So this is the region we are putting on one side. On the other side also, bilaterally the olfactory nerve is coming, number 1. Then from the orbit, the eyeball, the retina, comes the second cranial nerve, that is the optic nerve. We are going to mark it here now. This is the marking for the optic nerve, cranial nerve number 2. And you can see it is being marked on the left side. You can identify the optic nerve on the right side as well. The optic nerve will be passing the optic canal with a branch of the internal carotid artery, and that branch is called ophthalmic artery, following the optic nerve in the optic canal and supply the eyeball. So let us show the internal carotid artery here. This internal carotid artery was actually a content of the cavernous sinus, and after passing through the cavernous sinus, it will enter the cranial cavity. We are showing it on the left side from the superior view, and this is internal carotid artery on the right side. It will be giving the ophthalmic artery, which is passing through the optic canal along with the optic nerve. So that was cranial nerve number 2. Now we can locate the cranial nerve number 3 here, which has come from the brainstem, the midbrain, and now it is becoming a content of the cavernous sinus, which is lying lateral to the pituitary gland. You can see the cranial nerve number 3 on the other side as well, and this is the region of the pituitary gland. Pituitary gland is present in the midline at the floor of the middle cranial fossa. In the body of sphenoid, there is a depression, and we call it as sella turcica. So after we have seen the nerve number 1, 2, and 3, let us locate the number 4, which is quite thin, in fact the thinnest cranial nerve, and is evident here going into the cavernous sinus. It came from the midbrain and now it is passing into cavernous sinus, and close to that is the number 5, which is the trigeminal nerve, having lot of axons, the thickest cranial nerve. So it is to be understood that nerve number 4 is close to nerve number 5. Nerve number 4 is the thinnest cranial nerve, nerve number 5 is the thickest cranial nerve, and there this was the number 3, which is close to to nerve number 2. So in a sequence, nerve number 2 is close with nerve number 3 and nerve number 4 is close to nerve number 5. And then we can locate the nerve number 6 here. The nerve number 6 can be identified by the fact that as it is coming from the brainstem at the pontomedullary junction, it is going to puncture the dura mater in the posterior cranial fossa before it is passing through the Dorelius canal, and then it also has to enter the cavernous sinus. So here it is the sixth nerve, the abducens nerve on either side, and they are going to puncture the dura mater at the floor of the posterior cranial fossa, and then they have to enter the Dorelius canal before they become the content of the cavernous sinus. So this is the number 3, 4 and 6. They are going to supply the muscles of the eyeball, but after passing through cavernous sinus, they have to pass superior orbital fissure and then the orbit and supply the muscles of the eyeball. Now we have seen number 1, 2, 3, 4, 5, 6. Now 7 and 8 are passing in the internal auditory meatus. So as you see, this is going to be the facial nerve and the vestibulocochlear nerve. The number 8, several axons can be seen here, and then they are passing through this internal auditory meatus. And number 9, 10 and 11 can be seen passing into the jugular foramen. The number 11 will be having a cranial part coming from the brainstem, but a spinal part coming from spinal cord can be seen here. So spinal cord, which is below the foramen magnum, is sending the spinal part of accessory nerve, which you can trace here, and the spinal part of accessory nerve is meeting with the cranial part of accessory nerve, together making the accessory nerve the 11th nerve, and then the 11th nerve will be passing along with the number 9, 10 in the jugular foramen. Now remains the 12th nerve, and 12th nerve is hypoglossal nerve passing in the hypoglossal canal. It is coming from the brainstem and will have several rootlets, the axons which are passing here through the hypoglossal canal. So hypoglossal nerve in the hypoglossal canal can be seen on the left side as well as on the right side symmetrically. We will be focusing upon the superior orbital fissure now, looking at various structures passing through the superior orbital fissure, which is a gap between the floor of the anterior cranial fossa and the middle cranial fossa, or you can say it is a gap between the lesser wing of sphenoid and the greater wing of sphenoid. Orbit will be here, and at the apex of the orbit there will be a common tendinous ring of Zinn, giving origin to the 4 recti muscle of the eyeball. Let us try to put them here. This common tendinous ring of Zinn is present in such way that it will be at the apex of orbit, and through it is passing the optic nerve, cranial nerve number 2, along with the branch of internal carotid artery, the ophthalmic artery. So this is the common tendinous ring of Zinn, which we are showing on the right side. There will be similarly one on the left side from the superior view as we are looking from, and then this is a common tendinous origin of the 4 recti muscle: superior rectus, inferior rectus, lateral rectus and medial rectus. Plus this ring is covering the superior orbital fissure and dividing it into 3 parts. That can be seen in the next coming diagram now. So here once again we are looking from the superior view, focusing upon the right-sided common tendinous ring of Zinn, through which is passing the optic nerve and some other nerves. We are magnifying the diagram here. The nerves passing through the superior orbital fissure are 3 motor and 3 sensory nerves. The 3 motor nerves are supplying the muscles of eyeball, the number 3, the number 4 and the number 6. So 3 motor nerves are passing through the ring of Zinn and then superior orbital fissure. There are 3 sensory nerves also passing through the superior orbital fissure, and they are branches of the first division of trigeminal nerve, that is the ophthalmic division of trigeminal nerve. I'll give 3 sensory branches, and their names are L, F, N. L for the lacrimal nerve, F for the frontal nerve, and N for the nasociliary nerve. So these are the 3 sensory nerves which will be passing through the superior orbital fissure to enter the orbit and supply skin on the front of the face, coming here in this region. Now let us put the common tendinous ring of Zinn here. It is a structure which is at the apex of the orbit. In a magnified view, it will be something like this. And yet magnified view, you can see it now in this schematic diagram. So this is the common tendinous ring of Zinn, and it is giving origin to the 4 recti muscle. You can see this ring was observed here, and then it is magnified here. As we have mentioned, through the ring will be passing the optic nerve in the optic canal, along with the ophthalmic branch of internal carotid artery. Along with that, discovering superior orbital fissure, dividing into 3 parts: a part which is medial to that, a part which is lateral to that, and one part in the middle. And this common tendinous ring of Zinn, as you can see, is giving origin to 4 recti muscles: superior rectus, inferior rectus, medial rectus, and the lateral rectus. As you can see, through it is passing the optic nerve along with the ophthalmic branch of internal carotid artery to enter the orbit and supply the eyeball, and then the ring is dividing superior orbital fissure into 3 parts. lateral to the ring, medial to the ring, and in the middle. Now we have to remember there are total 6 nerves passing through the superior orbital fissure, 3 motor and 3 sensory. And the motor nerves, as we have mentioned, are number 3, 4, 6, supplying the muscles of the eyeball. And the 3 sensory branches are branches of ophthalmic, trigeminal, lacrimal, frontal, and nasociliary nerve. But then the arrangement is to be remembered. It is the LFT nerves which are left outside the ring of Zinn. L for lacrimal, F for the frontal, T for the trochlear nerve, lateral to medial. LFT nerves left outside the ring of Zinn. Then which nerves are passing inside the ring of Zinn? That will be nerve number 3, 6, and nasociliary. But you can see nerve number 3 has already given a superior and inferior division. And then you can see there is a number 6 and nasociliary nerve. So it appears that there are total 4 nerves passing the superior orbital fissure within the ring of Zinn, but actually there are 3, since the third nerve has given superior and inferior division. Superior division of oculomotor supplies superior rectus muscle in the eyeball. Inferior division will supply the inferior rectus. And then we can see there are 2 veins passing in the superior orbital fissure, the inferior ophthalmic vein and the superior ophthalmic vein. Superior ophthalmic vein is passing laterally and inferior ophthalmic vein is passing medially. None of them are passing inside the ring of Zinn because they might be compressed there in the crowded space. And these veins are coming from the orbit. They are draining into the cavernous sinus. So they are tributaries to the cavernous sinus. In the next diagram, we want to see the structures which are passing through foramen ovale. One of them will be the mandibular nerve, but along with that, there are some structures remembered by the mnemonic male. So let us move on to the next diagram. And it is again the superior view of the cranial cavity. We are focusing upon the right side. And in the greater wing of the sphenoid, we have the 3 foramina, the foramen rotundum, foramen ovale, and foramen spinosum. In the foramen rotundum, which is a round foramen, is passing the maxillary nerve to supply the bone maxilla. And in the foramen ovale, we have the mandibular nerve along with some more structures. Then there is a foramen spinosum. We are magnifying this foramen ovale and foramen spinosum, and you can see the various structures passing through the foramen ovale and spinosum here. It is the male structures which are passing through the foramen ovale and for the mandibular nerve. So in the male structures, the M is representing the mandibular nerve, and then A is the accessory meningeal artery, L is for the lesser petrosal nerve, and E is the emissary vein. But we have to remember this lesser petrosal nerve may sometime as a variation we found in the canaliculus innominatus. In that case, it will be absent from the foramen ovale. And in the foramen spinosum, we find there is a nervus spinosus, which is the meningeal branch of the mandibular nerve. It will arise from the mandibular nerve and re-enter the cranial cavity, called as the nervus spinosus, will be supplying the dura mater at the floor of middle cranial fossa in this region. And then along with the nervus spinosus, we have middle meningeal artery, which is a branch from the first part of the maxillary artery, and it enters the cranial cavity passing the foramen spinosum. As it enters here, it will be giving anterior and posterior division, and it was the anterior division. If you remember, it will be running towards the pterion. As we have remembered, if there is a fracture at the H-shaped suture, the pterion, the vessel which is bleeding is the anterior division of the middle meningeal artery, and that will result in extradural hemorrhage. Then we move on to the structures which are passing through the foramen magnum. It will be the brainstem, the lower part of medulla oblongata, which is passing through the foramen magnum. Below that is the vertebral canal, and there begins the spinal cord. So here you can show medulla oblongata covered by the pia mater. Exterior to that is the rectoid mater, and the meninges, which is outermost, will be the dura mater. Can be seen in the next diagram now. So here it is again the superior view of the cranial cavity. We are looking at the posterior cranial fossa, the foramen magnum. And in the foramen magnum, what we find is the lower part of medulla oblongata. Let us demarcate it here now. So this is the lower part of medulla oblongata, which will then continue as the spinal cord inferiorly in the vertebral canal. Now this medulla oblongata is covered by a membrane which is called as the pia mater, and this pia mater is further covered by the arachnoid mater to the exterior. So this is the pia mater, and then we have got the arachnoid mater still exterior, and then the outermost meninges will be the dura mater. Let us demarcate that as well. So here comes the dura mater, and then there will be some spaces as well. If it is deep to the dura mater, we are calling it as subdural space. So here we can understand this is the dura mater. Deep to that is the subdural space. Then comes the arachnoid mater, and deep to that, under that is subarachnoid space. This is filled with CSF, and in this subarachnoid space, which is filled with CSF, let us show some of the vessels. And as we are telling, this is the subarachnoid space. There we find 2 vessels, the vertebral arteries. As as we zoom them now, you can find these two vertebral arteries would have entered the foramen magnum after puncturing the dura mater. So third part of vertebral artery punctures the dura mater and then enters the foramen magnum to become fourth part of vertebral artery. Then they unite to form basilar artery and run on the base of the pons in the brainstem. They'll be giving some branches, like you can see. The vertebral arteries will give one anterior spinal each, but they fuse in the midline and run on the anterior side of medulla oblongata as a midline anterior spinal artery downwards towards the spinal cord. So you can see this is the third artery, anterior spinal artery in the foramen magnum on the anterior aspect of the medulla oblongata and the spinal cord as well. The spinal cord has given the spinal accessory nerve, and which has to enter the cranial cavity passing the foramen magnum. So here we can show spinal part of the accessory nerve which will enter the cranial cavity passing foramen magnum. In the foramen magnum we can see that some part of the cerebellum, that is the tonsillar part of cerebellum, can be present. And then we have to discuss the structures on the anterior aspect of the foramen magnum. Let us zoom out a bit now, and as we do that we need to understand there are some craniovertebral joints between the cranial bone, that is the occipital bone, and the vertebra which are inferior to that, C1, C2 vertebra, the atlas axis vertebra. Like you know, there will be atlanto-occipital joint, craniovertebral joint. Now the C2 vertebra, axis vertebra, will have a dens, and on the apex of dens there is one ligament attaching which is called as apical ligament of dens passing the foramen magnum, and it will be attaching here on the clivus part of the occipital bone. So as you can see, this is the apical ligament of the dens attaching to the apex of the dens of the axis bone, C2 bone. In the craniovertebral joint we also have one cross-shaped ligament, cruciform ligament, and will have a superior inferior band, transverse band. So superior band is passing here in the foramen magnum, and then it will also be coming from here and attaching to the occipital bone inside here on the interior. Then comes one more ligament which is the membrana tectoria, and membrana tectoria is the continuation of the posterior longitudinal ligament which is running posterior to the body of the vertebra in the vertebral canal. So it is coming from inferior to superior. The posterior longitudinal ligament becomes membrana tectoria, and then it will be passing foramen magnum to attach to the occipital bone on the interior. So three structures as we see are passing through foramen magnum to enter the cranial cavity and then attach to the clivus part of the occipital bone. In the next coming diagram, we will be focusing upon the content of the cavernous sinus. But not in this view, we are going to look at the cavernous sinus from the front view. So let us move on to the next diagram. And as you can see, it is the front view. There is a coronal section we have taken. Right in the midline in the sella turcica will be the pituitary gland. And on the either side of pituitary gland will be cavernous sinus. Inside the cavernous sinus, there is one artery passing along with some of the cranial nerves, which we have discussed earlier. And we are going to zoom this area now. Looking from the front view, you will notice that the sphenoid bone is a pneumatic bone. So it is having pneumatic spaces, sphenoid air sinuses in the body of the sphenoid. There you have sella turcica at the floor of the middle cranial fossa. This is the pituitary gland, and lateral to that is cavernous sinus. Cavernous sinus is a dural venous sinuses which is receiving tributaries from various sources like the brain drain into cavernous sinus. So that blue blood you can see passing inside the cavernous sinus is internal carotid artery and some of the cranial nerves. Let us zoom this diagram a little bit again, and then we can describe the further details. So looking from the front view, pituitary gland, on the lateral side are the cavernous sinuses, and which are still magnified there. This is the pituitary gland which you can find here, and then we are focusing upon the left-sided cavernous sinus, the content of cavernous sinus on the left side. So as we are marking the pituitary gland, which is also called as hypophysis, it is in the sella turcica, body of sphenoid. And then we have to understand the dura mater is splitting up into two components now. As we understand that the brain is covered by certain meninges, the outermost is dura mater, then we have rectoid mater, then we have the pia mater, and it is the outermost dura mater which is splitting into two layers. One which follow the bone, the sphenoid bone, is called as endosteal layer, and the one which follow the other meninges is called as the meningeal layer of the dura mater. So let us show the splitting up now. As you see, dura mater is splitting into this endosteal layer of the dura mater following the bone, the the sphenoid bone, whereas the meningeal layer of dura mater is following the meninges and enclosing one intradural space, the dural venous sinus. So as the layer is splitting, it is enclosing this cavernous sinus. And in the intradural space, you have some contents. Like this is the internal carotid artery passing through the intradural space. The internal carotid artery is in the intradural space, and then it comes out and enters the subarachnoid space, giving some branches, intracranial branches. But our focus is what all is inside the cavernous sinus. Running inferolateral to the internal carotid artery is the abducens nerve, and it is running alone as compared with the other nerves, number 3, 4, 5, 1 and 5, 2. That is the oculomotor, trochlear nerve, ophthalmic division trigeminal, maxillary division trigeminal. They are running together in the lateral wall of the cavernous sinus. Content of the cavernous sinus in the intradural space. And if there is any pathology here, these nerves can be compromised and the muscles of the eyeball will be compromised. So for example, in cavernous sinus thrombosis, there can be external ophthalmoplegia with some sensory disturbances in the territory of the trigeminal ophthalmic branch, trigeminal maxillary branch. But mandibular nerve is not a content of the cavernous sinus. So there will be no sensory disturbance or motor disturbance in the territory of mandibular nerve in cavernous sinus thrombosis. In the next diagrams, we are supposed to follow the nerve number 3, 4, 6 and then the nerve number 5, its branches as they arise from the brainstem and reach their respective target structure. So let us focus upon nerve number 3, 4, 6 first. We are looking from the lateral view and we understand that there is a formula LR6SO4 remainder 3, which is telling us lateral rectus is supplied by 6th nerve, superior oblique by 4th nerve, and rest of the eyeball muscle by nerve number 3. So it is the oculomotor nerve which is supplying almost all the eyeball muscles except the lateral rectus to be supplied by 6th, the abducens, and superior oblique to be supplied by the 4th, the trochlear. Let us first focus upon the oculomotor nerve here. The oculomotor nerve or the trochlear nerve, both of them are coming from the midbrain. It is the upper midbrain which will have the nucleus for the oculomotor nerve, and this oculomotor nerve fibers are now exiting from the upper midbrain anteriorly, divided into two branches, upper and lower division, and there is a time when it was passing through the superior orbital fissure inside the ring of Zen. We have seen inside the ring of Zen, we have the upper and lower division of the oculomotor nerve. Upper division supplying the superior rectus and lower division supplying the inferior rectus. Not only this nerve is supplying the superior rectus and the inferior rectus, but it is also supplying the inferior oblique muscle, the medial rectus muscle, and then we can move on to the trochlear nerve, the nerve which is supposed to supply superior oblique muscle. Even the trochlear nerve is coming from the midbrain, but it is the lower midbrain. It is having a nucleus, and this is the only cranial nerve which has a dorsal exit from the brainstem. So all the cranial nerves are exiting ventral, 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 but the only cranial nerve which exits dorsal from the brainstem is trochlear nerve, and that is why the trochlear nerve has the longest intracranial course. Comes as a question. Now this trochlear nerve, as it comes from the midbrain dorsally, it comes ventral because it has to supply the muscle of the eyeball. So it has to come ventral, and then it is passing through superior orbital fissure, but left outside the ring of Zen. As we remember, LFT nerves are left outside the ring. Trochlear nerve is left outside the ring of Zen when it is passing superior orbital fissure, and then it is going to supply the muscle which is the superior oblique muscle. We have to remember one thing, may it be nerve number 3 or 4 or 6, they're all content of cavernous sinus. As they come from the brainstem, they have to travel in the subarachnoid space, then they enter the cavernous sinus which is intradural space, and then they have to enter the superior orbital fissure to enter the orbit and supply the muscles of the eyeball. That is why we mention if there is a cavernous sinus thrombosis, these nerves can be compromised, leading to external ophthalmoplegia, paralysis of these skeletal muscles. Now, as we talk about the lateral rectus supplied by 6th nerve, the abducens nerve has a nucleus in the lower pons, but the nerve is exiting at the pontomedullary junction, as is evident here. So nucleus is in the pons, nerve exits at pontomedullary junction, is in the subarachnoid space, but it punctures dura mater quite early, and that is why the abducens nerve has longest intradural course. It is running through the cavernous sinus after that, which is also in the intradural space. We'll be looking at one diagram to discuss more detail of abducens nerve, but after passing through cavernous sinus, it is entering the superior orbital fissure and is a content of the common tendinous ring of Zen. And then LR6 means it is going to supply the lateral rectus muscle. So here we have learnt one thing. Which nerve has the longest intracranial course? That is the trochlear nerve. It becomes long because first it goes posterior, then it comes anterior. But this longest intracranial course, mostly it is in the subarachnoid space. If you say which nerve has the longest intradural space, then you have to talk about the abducens nerve. And how is that? Let us look at the details in the next diagram. So looking at the side view once again, talking about the abducens nerve in detail, this nerve is having a nucleus in the pons, but the exit of the axon is at pontomedullary junction in the posterior cranial fossa, and for a short distance, it is running in the subarachnoid space. So here is the nucleus in the lower pons. The nerve has come out at the pontomedullary junction, is running in the subarachnoid space, then punctures the dura mater and becomes intradural in the posterior cranial fossa. It is running on this bone clivus on the posterior cranial fossa, which is contributed by inferiorly the occipital bone, superiorly the body of the sphenoid bone. And after puncturing the dura mater in the posterior cranial fossa, it is running in the Doral's canal. Then it is taking a sharp bend over the petrous temporal bone and is passing in the middle of the cavernous sinus alone. That means it is a nerve which is not in the lateral wall of the cavernous sinus. It is running in the center of the cavernous sinus through the cavernous sinus and is located inferolateral to the internal carotid artery inside the cavernous sinus. So there are some reasons why whenever there is a raise in the cranial tension, the first nerve to get involved is abducens nerve. It has a long intracranial course and is having a sharp bend over petrous temporal bone. It is running alone through the cavernous sinus, not in the lateral wall of cavernous sinus, making it prone to be injured earliest whenever there is a raise in the cranial tension. Now, the abducens nerve is passing through a superior orbital fissure inside the common tendinous ring of Zen and then supply the lateral rectus muscle LR6. So as you see, passing superior orbital fissure inside the ring of Zen, which is also called annulus of Zen, and then supply the lateral rectus muscle. We will be looking at the superior view of the abducens nerve now in another diagram. And as we move on to that diagram, we are focusing upon the right side of the cranial cavity. From the brainstem at the pontomedullary junction, you have the abducens nerve passing in this region and ultimately supplying the muscle lateral rectus in the eyeball. So as we see, the nucleus of the abducens nerve is in the lower pons, but the nerve is exiting at the pontomedullary junction, and then it is becoming a content of the cavernous sinus running inferolateral to the internal carotid artery, and then it has to pass the superior orbital fissure. In the superior orbital fissure, it is a content of the common tendinous ring of Zen. Entering the orbit, it will supply the muscle lateral rectus muscle. Now there is one additional point which we have to focus upon in the course of this nerve. It lies deep to what is called as facial colliculus, which is produced by the axons of the facial nerve. So the motor nucleus of facial nerve, which is present in the lower pons, is sending the fibers towards the dorsal side, which will make a bend around the nucleus of the abducens, which is called internal genu of the facial nerve, and then it will be coming ventral to exit at pontomedullary junction, but lateral to the abducens nerve. So this is the facial nerve. Now, when the facial nerve fibers are making internal genu around the nucleus of abducens nerve, they produce a rounded elevation in the lower pons called as facial colliculus. Whenever there is an injury to facial colliculus, the fibers of facial nerve will be compromised, and the muscles of facial expression, like the risorius muscle, can be compromised. But if the lesion is still deeper, it can damage the nucleus of abducens nerve, and in that case, the lateral rectus will also get compromised, along with the muscles of the facial expression. As we focus upon the trigeminal nerve now, looking from the side view, we are calling this nerve trigeminal because it is giving the 3 division. It is a mixed nerve which is sensory motor, but the first 2 divisions are pure sensory divisions. As you can see, ophthalmic division and the maxillary division, they are pure sensory nerves. Whereas the mandibular division is a mixed nerve. It is going to have some sensory distribution, plus it is supplying the muscles of the mastication, developing in the first pharyngeal arch. Mandibular nerve is the nerve of first pharyngeal arch supplying the muscles of mastication. Now this trigeminal nerve, which is coming from the pons, is the thickest cranial nerve, having large number of axons because 3 nerves are coming into one nerve, so largest or the thickest cranial nerve, and giving 3 branches. After the trigeminal ganglion, we see the first division, ophthalmic division of trigeminal nerve is passing through the cavernous sinus. So the cavernous sinus will have phi 1 and phi 2 passing, that is the ophthalmic division and maxillary division. They are content of cavernous sinus, whereas mandibular nerve is not a content of the cavernous sinus. That is why it is spared if there is a case of cavernous sinus thrombosis. So what will be a problem in cavernous sinus thrombosis? The sensations which are supplied by these branches will be compromised. For example, ophthalmic division supplies the skin on the forehead and till the upper eyelid. There will be some sensory disturbances. Plus the maxillary division supply the skin over the maxilla, that is the upper lip and also the lower eyelid. So even that area will be involved. Sensory disturbance on the skin and the related territory. But there will be no sensory loss on the skin on the mandible, which is including the lower lip and skin on the mandible, because that is the territory of mandibular nerve, which is spared in cavernous sinus thrombosis. Plus there will be no problem with the muscles of mastication as well. Now, we are following this first division of trigeminal nerve, ophthalmic division. It is a content of cavernous sinus and then it is giving 3 branches which we have named as LFN, lacrimal, frontal and nasociliary nerve. They were passing through the superior orbital fissure, and if you remember, LFT nerves are left outside the ring of Zinn. That means the lacrimal and frontal nerve are left outside the ring of Zinn, whereas nasociliary nerve is passing inside the ring of Zinn. But all the 3 are passing through superior orbital fissure to enter the orbit and supply the skin on the forehead and the upper eyelid as well. Lacrimal, frontal and nasociliary nerve. Then we talk about the maxillary division of trigeminal, supply the maxilla bone, skin over maxilla and the upper teeth also. To supply the upper teeth, the maxillary division will be giving superior alveolar nerve as are evident here. And which nerve is giving inferior alveolar nerve? That will be the branches of the mandibular nerve. So as we follow the mandibular nerve, we have mentioned the mandibular nerve come distal to the trigeminal ganglion, is not a content of the cavernous sinus, passes through the foramen ovale and then it is giving anterior division and posterior division. Anterior division is mostly motor supply and it is supplying the muscles of the mastication, as we have discussed. Muscles developing in the first pharyngeal arch. The nerve of first pharyngeal arch is mandibular nerve, branch of trigeminal nerve. And what about the posterior division? Posterior division is mainly sensory. It is giving 3 branches which you can remember by the mnemonic PALI. P for posterior division and A for auriculotemporal nerve, L for lingual nerve, I for inferior alveolar nerve. So as we follow them, the A auriculotemporal nerve is going posterior from the posterior division. L is the lingual nerve going towards the tongue, as the name is suggesting, taking sensory supply from the tongue. And I is the inferior alveolar nerve passing into the foramen of the mandible and giving branches to the lower teeth called as inferior alveolar nerve. Next, we talk about the masseter reflex, which is controlling the muscles of mastication, and we have to talk about the motor nucleus of trigeminal, which will move the masseter muscle for the reflex. But we also need to talk about the sensory component, which is going to detect the movement of the mandible bone. And for that, we have got a diagram. Again, looking from the lateral view, the side view, in masseter reflex, what is also called as the jaw jerk, we are moving the jaw, which is change of position of the mandible. So it will be by a sensory nucleus, and then reflexively the masseter muscle will be contracting and there will be a motor nucleus working for the same. Here is the trigeminal ganglion and will have some sensory motor fibers. When we are talking about the motor nucleus which control the muscles of mastication, it is present in the pons. So motor nucleus is the nucleus to control the muscles of mastication, muscles of first pharyngeal arch. And then there are 3 sensory nuclei. The main sensory nucleus is in the pons, whereas there are some collection of neuron bodies moving into the midbrain, which is also called mesencephalon, hence the mesencephalic nucleus, which is moving towards the midbrain. Then there are some group of neurons which are moving towards the spinal cord, passing the medulla oblongata, and hence they are called as spinal nucleus of trigeminal. So there are 3 sensory nuclei. Now this spinal sensory nucleus of trigeminal is to receive the pain and temperature from the same side of the face. So pain and temperature from one side of the face will be reaching spinal sensory nucleus of trigeminal. trigeminal. Whereas if you touch the face, that is to be received by the main sensory nucleus of trigeminal. And when we are talking about change of position, the proprioception, maybe the mandible is moving, the tongue is moving, the eyeball is moving, that is to be detected by the mesencephalic sensory nucleus of trigeminal. It is detecting proprioception, that is change of position of the various structures. And this is the one which we'll be concerned about when we are talking about the jaw jerk. We have got a separate diagram for the same. In the jaw jerk or the masseter reflex, we take the knee hammer and we are going to hit the mentum of the mandible so that the mandible is going down. There is a change of position of the mandible, and that change of position or proprioception is then carried by mandibular branch of trigeminal nerve. Let us follow this course now. Proprioception is being carried by mandibular division of the trigeminal nerve towards the mesencephalic sensory nucleus of trigeminal, which we have discussed are some neuron bodies extending into the midbrain, and from there the information will be passed on to the motor nucleus of trigeminal, which is there in the pons, controlling the muscles of mastication. And then this motor nucleus of the trigeminal will be sending the efferent fibers through the same nerve, which is mandibular division of trigeminal, towards the muscles of mastication. So as we follow this pathway, the motor nucleus of trigeminal is sending impulses to the masseter muscle, which is an elevator of the mandible, and in response the mandible will be elevated. So what we have done, by hitting the mentum down, we were moving the mandible down, and reflexively in a very short duration the mandible has come back. These reflexes cannot be controlled at our will, they are automatic. So that change of position, the proprioception, and then the movement of the masseter, the motor nerve, is a single nerve, mandibular nerve branch of trigeminal, carrying out the jaw jerk or the masseter reflex. Nucleus tractus solitarius. It will be a sensory nucleus having two components, the tip and the bottom, upper portion and the lower portion. The tip will be receiving the taste sensation and the bottom will be receiving some sensations like the chemoreception, pressoreception. For example, blood pH or blood pressure. Before we start discussing about the lower part of nucleus tractus solitarius, let us focus upon the tip of the nucleus tractus solitarius for the taste sensation. And we zoom this diagram now. As we understand, the taste sensation will be carried by the FGV nerve. F is the facial, G is the glossopharyngeal, V is the vagus nerve. So anterior 2/3 of the tongue, the taste sensation will be carried by the cauda tympani nerve, branch of the facial nerve, as is evident here, reaching the tip of the nucleus tractus solitarius, the facial nerve. Then posterior 1/3 of the tongue, taste sensation is carried by the glossopharyngeal nerve. It is also carrying the taste sensation towards the nucleus tractus solitarius, upper portion. Then comes the vagus nerve from the posterior most tongue and also the epiglottis. So this is the vagus nerve carrying the taste sensation to the tip of nucleus tractus solitarius. Now we have to talk about the lower portion of the nucleus tractus solitarius and the sensations which it is going to receive in the next diagram. Here we are looking at the heart and the blood vessels coming from there, especially the common carotid artery, internal carotid artery. At the bifurcation of common carotid artery towards the internal carotid artery, we have got carotid body, carotid sinus. And at the beginning of this internal carotid artery, the carotid sinus was receiving the blood pressure sensation inside the blood. Or it could be the chemical composition, for example, pH of the blood, CO2 level of the blood. Now these sensations are to be carried by glossopharyngeal nerve. And the glossopharyngeal nerve is carrying the sensations towards the lower portion or the bottom of nucleus tractus solitarius in the medulla oblongata of the brainstem. Let us zoom this area a little bit now, and as we see, this nucleus tractus solitarius is now sending information towards the other nuclei, for example, dorsal nucleus of vagus, which is a parasympathetic nucleus. Now vagus nerve is cardio-inhibitory, and as you see from the dorsal nucleus of vagus, the fibers are coming down and they'll be working at the SA node. They can reduce the 3C, the contractility, the conductivity and the chronicity, that is the heart rate. But vagus nerve works upon SA node, works upon the atrial level. So for example, there was a situation when there was high blood pressure, and that high blood pressure is detected by the carotid sinus, by the glossopharyngeal nerve, which tells the nucleus tractus solitarius, further tells the dorsal nucleus of vagus, causes cardio inhibition, and the cardiac contractility, conductivity, chronicity goes down, and eventually the blood pressure will be going down. So it is also a reflex mediated by nerve number 9, nerve number 10. The sensory nucleus is lower part of nucleus tractus solitarius, and the motor nucleus is dorsal nucleus of vagus, one parasympathetic nucleus of the vagus. As we move on to discuss the details of the neural column, we already have discussed several nuclei. While we were discussing the number 3, 4, 6, there are motor nuclei, then the trigeminal nerve, the motor sensory nuclei, the jaw jerk. Then we have talked about the facial nerve, glossopharyngeal nerve, the vagus nerve, the number 7, 9, 10. There are nuclei like nucleus tractus solitarius, dorsal nucleus of vagus. All these nuclei, embryologically, how they are developing can be discussed in the neural columns. There are 7 neural columns, out of which 3 are motor and 4 are sensory. They will be having several nuclei, but how do they appear right from the beginning? In the beginning, we know there is a neural tube, and if we take a section of the developing neural tube, what we find is in the transverse section of the neural tube, a sulcus will be developing, and that sulcus is called as the sulcus limitans, as it is limiting the anterior basal plate from the posterior alar plate. So we have taken a transverse section of the developing neural tube, and there is a sulcus limitans limiting anterior basal plate from the posterior alar plate. In the posterior alar plate develops the afferent column. Afferent means sensory. So 4 sensory column, and anterior basal plate will have the 3 motor column. That will become more evident in the next coming diagrams. So here is the neural tube. We have taken the transverse section, and this is the sulcus limitans. It is limiting the anterior basal plate from the posterior alar plate. Alar means afferent. Afferent means sensory. So some sensory columns will be developing, 4 of them, and when you say anterior basal plate, there will be some motor neurons controlling some muscles. Now these red neurons which you are seeing here will be forming anterior horn cell and lateral horn cell of the developing spinal cord. So as we are mentioning, this is the anterior basal plate. The red color neurons, they are forming anterior horn cells, which are also called as the ventral horn cells. And then there are laterally located the intermediolateral horn cells, and these are motor neurons. They are going to control some muscles. The anterior horn cells, they are controlling the skeletal muscles, whereas the intermediolateral horn cells, they are controlling the visceral muscles, which could be the cardiac or smooth muscles. So there will be some names given to them, the neural columns. For example, the anterior horn cells are controlling the skeletal muscles, they are called as GSC, whereas intermediolateral horn cells, they are controlling the visceral muscles, they are called as the GVE. Now, what does these terms mean? G is for general, like there is a general category of muscles, special category of muscles, but here we are talking about general category of muscles. E is efferent. Efferent means muscles. So general, what is S for? S is somatic, the skeletal muscle. So G for general category, S for somatic or skeletal muscle, E is muscle itself. So here, these neurons are under GSC neural column controlling most of the skeletal muscles in our body, but there are some skeletal muscles which are special muscles. So we'll be talking about them separately. And then what about the GVE? G for general, they're not special. And E for efferent, the muscles. And which muscles? The visceral muscles. So these neurons, they control cardiac smooth muscles, which are visceral muscles in the general category. That is why GVE. Now, this is about the motor column. What about the sensory column? For example, the cardiac muscle is having pain, angina pain, or smooth muscle is having pain, the colicky pain. Then which neurons will be receiving that pain? That will be the posterior alar plate having the blue color posterior horn cell or dorsal horn cells. They are sensory neurons. They will be receiving the pain sensation. So as we are mentioning, the posterior alar plate is giving posterior horn cell, can also be mentioned as dorsal horn cell. And alar means afferent. Afferent means sensory, which could be either GVA or the GSA. Now, what is this GVA? GSA? As is understood, the counterpart of GVE will be GVA, and the counterpart of GSC will be GSA. The E will become A. Okay, that is understood, but what does it mean? See, general visceral muscles, if they have pain, there will be general visceral sensation. G for general, V for visceral, A for afferent sensation like angina pain, colicky pain. Then what is GSA? GSA, general somatic sensation. For example, the general skeletal muscle, they are having a spasm, skeletal muscle spasm, painful. So that pain will be received by these sensory neurons, posterior horn cells, and they are having a neural column GSA, general somatic sensation. This will become more clear in the next coming diagrams. We have seen 2 motor columns and 2 sensory columns here, the GSC GVE and the GSA GVA. Out of 7, we have discussed 4 of them here. And this is the diagram where we can discuss the motor columns, which will be 3 in number, and the sensory columns, which will be 4 in number. We have to understand when we say motor, motor means the muscles, and muscles are represented by the term efferent. Efferent is basically the outgoing fibers from the central nervous system and to control the muscles. So whenever we will use the term efferent, it means we are talking about some muscles. On the other hand, when we say sensory, sensory is going to be efferent, the incoming fibers, the sensations, they are coming towards the central nervous system. So efferent will be having 3 in number and efferent will be having 4 in number. Let us start with something which we already have discussed. Like we have told, most of the skeletal muscles, they are called as GSE. G for general because they are not special category, and S for somatic means they are skeletal or not visceral, you can say. Visceral means something which is inside. Somatic means which is outside, peripheral. So skeletal muscles are outside, they are peripheral. Somatic means not visceral, or you can say they are skeletal. And E we have already told, efferent, or what you can say, efferent means the muscle. So when you say GSE, general skeletal muscle, the muscles like biceps and triceps, they are under somatic nervous system. And then we have a category of GVE, general visceral muscle. So as we mentioned, GVE, G for general, means it is a general category, not a special category. And V is visceral. Visceral means something which is on the inside. Visceral is inside, somatic is outside. And what is E? E for efferent. Efferent means muscles. So general visceral muscles. That means it is the cardiac muscle and the smooth muscle. Even the glands, because glands will have smooth muscles. And these kind of muscles are under autonomic nervous system, which is GVE, and the somatic nervous system, which is GSE. Then we were talking about the skeletal muscle spasm will be carried by GSA. So let us carry the GSA sensation now, which is coming up here. The GSC will have GSA. G for general, S for somatic, and A for efferent. That means sensation, general somatic sensation, like skeletal muscle spasm. So if there is pain due to skeletal muscle spasm, GSC sensation will be carried by GSA. Then what about the cardiac pain, like angina pain, or smooth muscle pain, like colicky pain? If you have a GVE, the pain will be carried by GVA. And let us carry that now. The GVE pain will be carried by the GVA, general visceral sensation. So G for general, and V for visceral, and A for efferent sensation. For the GVE, we have the GVA, angina pain, colicky pain, a pain of general category which is coming from the viscera, from the inside. If the pain comes from outside, somatic. If it comes from inside, visceral. So you can mention here angina pain, colicky pain. Now, not only you are talking about angina pain, colicky pain, but even the chemoreception and the pressoreception. Like we have discussed, the carotid body, carotid sinus, the blood pH, blood pressure. There are also some sensation which are coming from inside the body, not from outside. So even the chemoreception and pressoreception, or the lower part of the nucleus tractus solitarius, if you remember, that comes under GVA. That is how we have to relate. Now, what else will you consider under the GSA then? Under GSA, you can see not only the skeletal muscle spasm, but along with that, as you can see, the term itself, general peripheral sensation, which could be, on the skin, touch, pain, temperature, pressure, vibration, proprioception, in the body wall, in the periphery. So they are all under GSA. Now, once you have told about GSA and GVA and their counterpart, the GVE and GSE, total 4 neural columns we have discussed, and 3 are remaining, out of which one will be motor, and then there will be 2 which are sensory. Before you start discussing sensory, let us discuss the motor. This third motor column is a boundary line column, going from skeletal, which is periphery, towards visceral, which is interior. Actually, some muscles develop which are in relation to the respiratory tube, the gut tube. Now, respiratory and gut tube, they are visceral tube, but in the initial part, they'll have some skeletal muscle. So this is creating a confusion, and actually we have got a misnomer. That misnomer is called SVE. As you can understand, they are some special category muscle. That is why S and E is representing efferent or muscle. As we know, V should be telling us about the visceral. And the term visceral comes because these muscles are developing around the visceral tubes, like the gut tube or the respiratory tube. So they are the boundary line muscles, and there is a misnomer here. This term SVE is a misnomer. But why you are telling that it is a misnomer? And which group of muscles are you including under this? The muscles which develop in relation to gut tube, respiratory tube, the pharyngeal arch muscles, like the muscles of mastication, muscles of facial expression, muscles of palate, pharynx and larynx. They are under HVE column. As you know, these muscles are all skeletal muscles, but they are being kept under the category of visceral muscle. That is why I am telling it is kind of a misnomer. So as you talk about HVE muscles, they are the pharyngeal arch muscles, and some of the examples you can take would be the muscles of palate, pharynx and larynx, the muscles for speech and swallowing. These are some examples, the skeletal muscles which are developing in arch number 3, 4, 6, and they are under the category SVE, special visceral muscle. Despite the fact that they are skeletal muscle, misnomer is they are called as visceral muscles. And similarly, we'll have a misnomer in the sensory area as well, that area. But at the moment, you have seen 3 motor column. One is GSC, one is GVE, and then one is SVE. SVE are the pharyngeal arch muscle, the skeletal muscles, wrongly called as visceral muscles. Then let us move on to the sensory component. We already have discussed one general somatic sensation, then general visceral sensation. What is left is 2 more sensory components. Now, this one is the SSA, and let us see why we are calling it as SSA. S is special, means it is not general, and the other S is somatic, means it is coming from periphery, not from inside the body. It is not visceral. And A is afferent. Afferent means sensation. So, special somatic sensation, or some special sensation which come from the periphery, like the vision, cranial nerve number 2 optic nerve, or hearing and balance, cranial nerve number 8 vestibulocochlear nerve. So, nerve number 2 and nerve number 8 you can mention here. Nerve number 2 for the vision and nerve number 8 for hearing and balance. They are under the category SSA. Now, there are 2 more special sensations, that is the smell and the taste, but they are called as SVA. Now, why are you calling them SVA? That is the special visceral sensations. These are not visceral sensations. Taste is coming from outside, smell is coming from outside. They should be SSA. Why are you calling them SVA? That is what I told you. Again, it is a misnomer kind of thing. It is understood that even the taste sensation and smell sensation, they are not coming from inside, they come from outside, and they should be called as SSA, but they are not called SSA, they are called SVA. And why they are called SVA? Special sensation of visceral nature. But why you are calling them visceral nature? Because the smell and the taste, they are developing around the visceral tube, respiratory tube and the gut tube. That is why maybe somebody has put the term visceral. So which nerve are carrying the taste? FGV nerve, facial, glossopharyngeal vagus. And which nerve are carrying the smell? Cranial nerve number 1, the olfactory nerve. So nerve number 1 for smell and nerve number 7, 9, 10 for taste sensation. They will be under the category SVA. And we have to continue this discussion of the 7 neural column in a table where we'll put the corresponding nuclei also in the brainstem. Here we have put the 7 neural columns in the tabular form, and it is some of the nuclei related with them. As we see in the brainstem, these are brainstem nuclei, and we are going to discuss them under the 3 motor column, that is GSC, SVE, GVE, and the 4 sensory columns. Before we start discussing the sensory column, let us come to the motor column. GSE. G is for general, S is for somatic or skeletal muscle, E is for the muscle. The general skeletal muscle are the most of the skeletal muscles in the body, or the muscles which do not develop in the pharyngeal arch. Say for example, the eyeball muscle, the tongue muscle. The eyeball muscle and the tongue muscles, they do not develop in the pharyngeal arch, and they are under the GSE category. Now the formula for the eyeball is the number 3, 4, 6. The nuclei can be seen here, and for the tongue it is nucleus number 12. We already have seen these nerves and their courses, their supply in the previous diagrams. It is to be understood that the number 3, 4 nuclei will be found in the midbrain, number 6 in the pons, and number 12 in the medulla oblongata. Then comes the category SVE, special visceral efferent. These are the pharyngeal arch muscles, as we have discussed, though they are called as the visceral muscles, but they are in fact skeletal muscles. So it is kind of a misnomer. Now, it can be seen that pharyngeal arch 1 will have trigeminal nerve for muscles of mastication. Arch number 2 is muscles of facial expression, the facial nerve, and then arch number 3, 4, and 6 muscles of palate, pharynx, and larynx, controlled by nucleus ambiguous. So this is trigeminal nerve for first arch, facial nerve for second arch. Their nuclei will be found in the pons, whereas in the medulla oblongata we are having this nucleus ambiguous, and nucleus ambiguous is having neuron bodies for number 9, 10, 11, which control the muscles of arch number 3, 4, and 6. And these muscles are basically the muscles of palate, pharynx, larynx, involved in speech and swallowing. So these muscles, they are all skeletal muscles, but coming under the category of special visceral muscles, SVE. Then we have the GVE, general visceral muscles, the cardiac and the smooth muscles. Now, when we talk about the cardiac and smooth muscles, this will be the autonomic nervous system. And since we are in the brainstem, the nuclei are parasympathetic nuclei. For example, in the midbrain, we have Edinger-Westphal nucleus for the nerve number 3. Parasympathetic nucleus controlling the two muscles in the eyeball, sphincter pupillae and ciliaris muscle. Now, the parasympathetic nucleus in the pons will be the superior salivatory nucleus for facial nerve, inferior salivatory nucleus for glossopharyngeal nerve. As the name is suggesting, salivatory nucleus. So they'll be controlling smooth muscles of the salivary gland on the face, and their nuclei are in the pons. Then in the medulla oblongata, we have a parasympathetic nucleus for the nerve vagus, dorsal nucleus of vagus, under the GVE category. So it is going to control cardiac muscle and smooth muscle in the body. Vagus nerve controlling the cardiac muscle or smooth muscle in various body tubes is under the category of GVE. So here we have seen the 3 motor columns and their nuclei in the brainstem. Now let us move on to the 4 sensory column. As we understand that there is a common nucleus for SVA and GVA, special visceral sensation, general visceral sensation. The nucleus, which is called as the nucleus tractus solitarius, is present in the medulla oblongata of the brainstem. So this nucleus tractus solitarius, tip is for the taste, and taste is carried by FGV nerve, facial glossopharyngeal vagus nerve, under the category SVA, special visceral sensation. We told it is kind of a misnomer. So the nucleus tractus solitarius, tip is for the taste nerve, involved are FGV, facial glossopharyngeal vagus nerve, bringing the taste sensation under the category SVA, special visceral sensation. Now, general visceral sensation, GVA, is the lower part of nucleus tractus solitarius, and those general visceral sensation could be carotid body, carotid sinus, chemoreception, pressoreception, coming to the bottom of nucleus tractus solitarius. Then we have discussed trigeminal nerve, which is under GSA, general somatic sensation. And for trigeminal nerve, there's a main sensory nucleus which is in the pons. Some neuron bodies were extending into midbrain, so that nucleus we were calling as mesencephalic sensory nucleus of trigeminal. And some of the neuron bodies moved into medulla oblongata towards the spinal cord, hence we were calling it as spinal sensory nucleus of trigeminal. After passing through medulla oblongata, it will enter the spinal cord. So what is this general somatic sensation, GSA, about? We touch the face, that is general somatic sensation received by main sensory nucleus of trigeminal in the pons. And what about the movement of the jaw jerk, masseter reflex, proprioception received by mesencephalic sensory nucleus of trigeminal in the mesencephalon, midbrain? And what about the pain and temperature from the same side of the face is received by spinal sensory nucleus of trigeminal? So this is all under GSA category. Then comes the SSA, special somatic sensation, number 2 and number 8. Number 8 is vestibulocochlear nerve for hearing and balance, and it is shown at the pontomedullary junction. At the pontomedullary junction, we have the vestibulocochlear nuclei for hearing and balance, and their special somatic sensation, SSA. Though optic nerve is also SSA, but you cannot show the optic nerve pathway coming to the brainstem. This is a discussion on brainstem nuclei, so only 8th nerve is shown, though we understand that even the vision and the hearing balance is under SSA neural column. So here we have seen 4 sensory column and their nuclei in the brainstem, plus 3 motor column and their nuclei in the brainstem. Development of pituitary gland. Pituitary gland is developing from the surface ectoderm lining the oral cavity, and also from the neural plate ectoderm, which is a downward extension from the diencephalon part of the brain. So as you look at this diagram, we have to understand that most of the pituitary gland is developing from here. As we know, in the initial part of the oral cavity, there will be lining of surface ectoderm. There develops a pouch which is called as the Rathke's pouch, and it is this Rathke's case pouch, surface ectoderm, which is going to contribute to most of the pituitary gland. But then pituitary gland is also developing from the neural plate ectoderm. Neural plate ectoderm was forming this neural tube and the brain here. In the developing brain, there will be a downward extension from the diencephalon, and that downward extension from the diencephalon will be forming the posterior pituitary, which is also called as pars nervosa or neurohypophysis. So as we mentioned here, you can tell this pars nervosa, which is also called neurohypophysis or the posterior pituitary, is actually coming as the downward extension from the diencephalon part of the brain, which is neural plate ectoderm. So it is derived from here, then it comes here, and then comes into the sella turcica at the floor of middle cranial fossa. This is the body of the sphenoid. But then most of the pituitary is actually shown in orange color, is coming from Rathke's pouch. As we said in the beginning, the oral cavity is lined by surface ectoderm, and that surface ectoderm at the roof of oral cavity is forming the Rathke's pouch, which will then contribute to the anterior pituitary or the intermediate pituitary or the pars tuberalis. Anterior pituitary is also called as adenohypophysis. So as we see, at the roof of oral cavity, surface ectoderm is contributing to Rathke's pouch, which is then moving towards the sphenoid bone and is contributing to anterior pituitary or adenohypophysis, plus the intermediate pituitary and the pars tuberalis as well. One applied aspect can be understood here sometime. A remnant of the Rathke's pouch can produce what is called as craniopharyngioma, which can be seen in the sphenoid bone at the level of the sella turcica, or it can be in the path of the normal development, like from here. When Rathke's pouch is moving towards the sphenoid bone, the tumor can be either in the sphenoid bone or somewhere in the path. For example, roof of the nasopharynx. So as you show here, this could be the location of what is called as craniopharyngioma, the pituitary tumor. Now we are looking at one radiological picture, and what happens is these days the examiner might be giving you some diagrams and putting marker ABCD, asking you to identify various structures. So here we are looking from the lateral view. It is kind of a sagittal section, anterior to posterior, and we can focus upon different parts of the brain. Telencephalon, the cerebral hemisphere; diencephalon, the thalamus, hypothalamus. Then we have mesencephalon, midbrain; the metencephalon, which is pons and cerebellum; the mesencephalon, medulla oblongata, and then the spinal cord. So as you are marking the cerebral hemisphere, one-sided cerebral hemisphere is evident here under the telencephalon part of the brain. Then you can also discuss the diencephalon part of the brain, which is actually the thalamus and the hypothalamus. So here is the thalamus, which is separated by hypothalamic sulcus. Above is the thalamus, below is the hypothalamus. And then comes the midbrain. Midbrain can be identified by tectum on the posterior side, having superior inferior colliculi, tegmentum on the anterior side. So as we are looking at the superior colliculus, inferior colliculus, this is the region of the midbrain, and below that will be the pons. Now once we have marked the pons, below that is the medulla oblongata, which will be then passing through the foramen magnum. So this is the medulla oblongata, and here is the edge of the foramen magnum. After passing foramen magnum, it will continue downward in the vertebral canal as the spinal cord. But we have to understand that the spinal cord is not in the foramen magnum. In the foramen magnum, what we have is lower part of medulla oblongata, and even the cerebellar tonsils are there in the foramen magnum. So this is the cerebellum, as you can make out. We can demarcate it here. One of the cerebellar hemisphere is evident here, connected to the brainstem with the help of the peduncles. That is the superior cerebellar peduncle for midbrain, middle for the pons, inferior for the medulla oblongata. And when we are talking about the CSF flow, most of the CSF is formed in the lateral ventricle, which is C-shaped, present inside the cerebrum, and from the lateral ventricles it will be passing interventricular foramen to enter the third ventricle, which is sandwiched between thalamus and hypothalamus. So we are now following the CSF circulation from the lateral ventricle, interventricular foramen Monro, hypothalamic sulcus, then the aqueduct sylvius in the midbrain, and after that it will be entering the fourth ventricle, which is a diamond-shaped ventricle sandwiched between the cerebellum posteriorly and and pons upper half of medulla anteriorly. So from the lateral ventricle, the CSF has entered foramen Monro, hypothalamic sulcus in the third ventricle, then in the midbrain aqueduct of Sylvius, there's the fourth ventricle, and then it will be entering the central canal in the lower half of medulla and thence into the spinal cord. You can show the CSF flow now into lower half of medulla and into the spinal cord. Now coming back to the cerebrum. Cerebrum will have some lobes. On the front you have frontal lobe, then we have one parietal lobe, and posteriorly we have the occipital lobe. To separate the frontal and the parietal lobe, we will have a central sulcus. But central sulcus is not in the center, it is slightly posterior. So we can show the central sulcus, which is not so evident on the medial surface. So this is the central sulcus separating frontal lobe on the front and parietal lobe posterior. Actually, what you find right in the middle of cerebrum is not the central sulcus, but pre-central sulcus. So this is what we are calling as pre-central sulcus, which appears to be in the middle of the cerebrum. Now, if this is the central sulcus, around that is the paracentral lobule. And this paracentral lobule is the sensory motor area for lower limb and pelvis perineum. In front of the central sulcus, we have the frontal motor cortex to control lower limb muscle, pelvis perineum, and posterior to the central sulcus is the parietal sensory cortex, receiving sensation of lower limb and pelvis perineum. Any vascular injury in this area can result in sensory motor loss of the lower limb and the pelvis perineum. Now, as we go posterior, how do you separate parietal lobe from the occipital lobe? There is a parieto-occipital sulcus, as is evident here, and as we are marking the parieto-occipital sulcus to separate parietal from occipital lobe, in the occipital lobe, we are having a calcarine sulcus. This calcarine sulcus, which is in the occipital lobe, is the area where we have area number 17, Broadband number, occipital visual cortex. So this was about the cerebrum. You are connecting one half of cerebrum with the other half of cerebrum with some axons making the corpus callosum, which is itself C-shape. So we can mark the corpus callosum here, and it is basically connecting one part of the cerebrum with other part of the cerebrum. We'll be having certain portions like it is having a rostrum, a bend the genu, then it is having a trunk, and then the splenium. In the splenium, it is connecting one occipital lobe with the other occipital lobe, and the trunk of the corpus callosum is connecting the parietal and temporal lobe of one side with the other side, crossing the midline. And in the region of the rostrum, you are connecting the orbitofrontal cortex of right side with the left side. The fibers are crossing in the midline, the commissure fiber, the corpus callosum. Then in this diagram, we can see a downward extension of the diencephalon towards the eyeball, and we call it as the optic nerve. So here is the downward extension of diencephalon, the optic nerve, and from the diencephalon comes the posterior pituitary also, the neurohypophysis. So from the diencephalon comes the posterior pituitary, the neurohypophysis. Pituitary gland is having anterior pituitary also, coming from the rat case pouch developmentally, and this is the location of the pituitary gland, which is in the body of the sphenoid called as the sella turcica at the floor of middle cranial fossa in the body of sphenoid. We know sphenoid bone is a pneumatic bone, so what is evident is sphenoidal air sinus here. When we discuss the white matter fibers, that is the collection of axons, it is into three categories. We can classify it: the association fibers, commercial fibers, projection fibers. Now, talking about the association fibers, they are connecting parts of the brain on one side without crossing the midline of the body. As you can observe here, this diagram we are looking from the front view. We have taken a coronal section, and in the coronal section, what you find is the association fibers, the axons which are connecting one part of the brain with the other part of brain, like the Wernicke's sensory speech area with the Broca's motor speech area. We have a diagram for the same. We'll be discussing it separately, but this will be arcuate fibers, the association fibers, connecting one part of brain with the other without crossing the midline. And the same you can show here as well. When the fibers are not crossing the midline, connecting only parts of brain on the same side, the association fibers. Next, we can talk about the commercial fibers. We know commercial commercial fibers are going to cross the midline and connecting one part of brain, the right part of brain, with the left part of the brain. And one good example is this corpus callosum, connecting right with the left brain. So this is the corpus callosum, and it is a good example of the commercial fibers. Then, as we are talking about the third category, projection fibers, it is the internal capsule we can discuss. So in the projection fibers, we are talking about these axons which are connecting the higher brain center with the lower brain center and vice versa. That is the internal capsule on the left side and right side from the front view. And we have learned that this internal capsule developmentally, it was bisecting the corpus striatum into two parts. So which two parts of the corpus striatum it produces developmentally? We have learned L for L. The lentiform nucleus will be lateral to the internal capsule, whereas this is the caudate nucleus, medial to the internal capsule. Together they are called as corpus striatum, part of the basal ganglia. So here the C is for caudate nucleus, located more medially. Now let us focus upon this structure here at the roof of the third ventricle, which is called as the fornix. When we are talking about the fornix, it is to be understood that the fornix is chiefly the commercial fibers connecting right-sided brain with the left-sided brain. So as you locate, this is the fused portion of the left and right fornix at the roof of the third ventricle, which is a midline ventricle, and fornix is chiefly the commercial fibers connecting the right hippocampus with the left hippocampus. But then be careful, fornix is not only having commercial fibers, it is also having the association fibers and projection fibers. So it has all the three types of fibers. You can remember it is having the cap, the commercial, the association, and projection fibers. But the first answer should always be commercial fibers. We'll be looking at some diagram for the fornix, but let us first start with the association fibers. The arcuate fasciculus connecting the Wernicke's sensory speech area with the Broca's area in the next diagram. In this diagram, we are looking from the left side, as left side is usually the dominant hemisphere for language processing, and then there will be one Wernicke's sensory speech area for comprehension of the language on the posterior part of the superior temporal gyrus, area number 22. So here, this is the Wernicke's sensory speech area, which is sending information to the Broca's motor speech area, which is area number 44-45 in the inferior frontal gyrus. So how are they connecting? They are having one arcuate fasciculus, bundle of axons running in arc-shaped fashion, connecting one part of the brain with the other part of the brain without crossing the midline. So the association fibers. Now, what will happen if there is a lesion in the arcuate fasciculus? Then there will be aphasia, and it is called as conduction aphasia. A patient with conduction aphasia is having difficulty in naming, difficulty in repetition of language, poor repetition of language. So this patient, the comprehension of language is fine, and even the fluency of the language is fine. But since there is a lesion in the arcuate fasciculus, there will be poor naming and poor repetition of language, conduction aphasia. Then talking about the commercial fibers, one of the good example is corpus callosum, and we are looking from the side view. In fact, we have taken one sagittal section anterior to posterior, and we are marking the corpus callosum in the dissected brain. That is a schematic diagram showing the same detail. So here, corpus callosum is a C-shaped structure having a rostrum, which is evident here in this diagram anteriorly, and then it is having a bend which is called as the genu, which is evident here. After that, there is a trunk or the body of the corpus callosum, which is mentioned here, the central part, and then there is one posterior part, the splenium, which you can show here in this diagram as well. So what is this splenium is connecting? Since these are all axons connecting right-sided brain with the left-sided brain, the splenium is connecting the occipital lobe of right side with the left side. Fibers will be passing through this. And what about the trunk region? The parietal and the temporal fibers of right side will be connecting with the left side through the trunk region, and the genu rostrum. Genu rostrum are connecting the frontal lobe fibers of right side with the left side. Rostrum is basically connecting the orbitofrontal cortex, which is just above the eyeball. The orbitofrontal cortex of right side connected to the left side with the help of the rostrum, part of the corpus callosum, the commercial fibers. We have to look at the corpus callosum from the superior view as well now after taking a transverse section. And as you can see, this was the side view we were discussing. The next diagram for comparison is superior view of the brain. We have taken a transverse section and we want to correlate the corpus callosum, these axons connecting right half of the brain with the left half, with the sagittal section. So here what you find is when we are talking about the genu portion, anteriorly it can be shown here as well, connecting the frontal lobe with the frontal lobe, and it is making what is called forceps minor. So the point is, genu portion connecting the frontal lobe of right and left side, the fibers when they are passing, they make collection of axons in a shape of forceps. We call it as forceps minor because there is a forceps major posteriorly. So what about this forceps major then? As we are connecting the occipital lobe of right side with the left side, these axons are making the forceps major, and this area, as is evident here, will be the splenium part of the corpus callosum. So splenium part of the corpus callosum, as we see, is the one which connect the right occipital lobe with the left occipital lobe. That is where we will have fibers of the forceps major. This is the region of the splenium in the forceps major. That was the part which was the genu in the forceps minor. Then what about the trunk region? In the trunk region, we will have the tapetum fibers, which can be shown now in this diagram connecting the temporoparietal part of the cerebrum. So as we are showing them here, the parietal lobe and the temporal lobe connected on the right-left side, these fibers are called as the tapetum fibers. And the tapetum fibers can be seen here in the trunk region or central part of the corpus callosum. We can remember one mnemonic here, T. And what is the full form of TTT? The tapetum fibers are in the trunk region connecting the temporal lobes. So if you want to connect right temporal lobe with the left temporal lobe, then you can use the tapetum fibers. But be careful, tapetum fibers not only are connecting the temporal lobe of right side with the left side, they are also connecting the parietal lobe. They are having temporoparietal fibers in the trunk region of corpus callosum. This was a sagittal section and that is a transverse section showing the fibers of the corpus callosum. And now comes the details of the fornix, having all the three types of fibers: the commissure, the association, and the projection fibers. As we look at this diagram from the front view, we can understand this is the green area showing the fornix. Magnified view is here, where you see the right-sided fornix and left-sided fornix, they have come close in the midline, forming the roof of the third ventricle in the midline. And if you're looking at the fornix from the side view, like you have taken a sagittal section, then it is appearing like a C-shaped structure, collection of axons, which are basically commissural fibers connecting one hippocampus with the other hippocampus across the midline, but they can also be association fibers and even the projection fibers. Let us look at the detail of the fornix when we talk about the Papez circuit. Papez circuit is a part of the limbic system, which is related with the emotions, behavior, memory of an individual, related with the smell pathway as well. And to discuss Papez circuit, we have got another diagram now. We need to start from the hippocampus region. Hippocampus is the seat of short-term memory, and if you want to consolidate the short-term memory into long-term memory, you can use this Papez circuit. The hippocampus is present in the inferior temporal lobe. As you can see, you can mark it here, the hippocampus region in the inferior temporal lobe. The major output tract from the hippocampus is the fornix, the C-shaped structure, collection of axons. So as we are telling, the fornix is a C-shaped structure, which is the major output from the hippocampus. Where is it going to send the synapsing fibers? So here we are showing the fornix, and fornix is reaching the hypothalamus, the mammillary body. Now, when you say it is reaching the mammillary body in the hypothalamus, you can show the mammillary body here in the diagram as well. So, as we are telling, from the hippocampus, the major output tract is fornix, and synapse is on the mammillary body of the hypothalamus. This is the hippocampus having short-term memory functionality, and if you want to consolidate the memory, send it via the fornix through the Papez circuit. Now, what will happen if we have a lesion in the fornix or in the mammillary body? The patient is having difficulty in recall of the memory and can have confabulation, filling in the gap of the recent loss of memory with some storytelling, confabulations. Now, in the Papez circuit, after the hypothalamus mammillary body, where the fibers are going, then we have got the mammillothalamic tract going to the anterior nucleus of thalamus. So, from the mammillary body, this is the pathway going to the anterior nucleus of thalamus, which you can show in the line line diagram as well, anterior nucleus of thalamus. This is the mammillothalamic tract, as is evident from the mammillary body, mammillothalamic tract, reaching the anterior nucleus of thalamus. Now, after this mammillothalamic tract, from the anterior nucleus of thalamus, where the fiber system is going, it will go above the corpus callosum into the cingulate gyrus and spread over the cerebrum. So, as we are continuing with the pathway, we find this pathway is spreading over to the cerebrum in the cingulate gyrus, as is evident here. And from the cingulate gyrus, this pathway is coming to entorhinal cortex in this region and eventually reach the hippocampus once again. So, as you can see from the anterior nucleus of thalamus, the pathway goes to the cingulate gyrus, and from the cingulate gyrus, it is reaching the entorhinal cortex, and from the entorhinal cortex, which is related with the smell, it is going back to the hippocampus. So, it is a complete circuit from the anterior nucleus of thalamus to the cingulate gyrus and coming back to the hippocampus. And the circuit keeps on going again and again for consolidation of the memory. This is Papez circuit, part of the limbic system, related with the emotions, behavior, smell, and memory of the individual. Phonics playing a major role, carrying not only the commissural fibers, but also association fibers and the projection fibers. Now we are talking about the extrapyramidal system and specifically the basal ganglia. In fact, the basal ganglia should be called as basal nuclei because ganglia is a misnomer. You cannot have ganglia inside the central nervous system. Under the basal nuclei, you will find there are some structural nuclei and which belong to telencephalon, and then there are some functional nuclei which do not belong to telencephalon. In the structural component, you will see there are certain names to memorize, like there is a comma-shaped caudate nucleus, and then there is a putamen. You will also see there is a globus pallidus. And as we are talking about the functional nuclei, here is the subthalamic nucleus, which is actually a part of the diencephalon, and then there is substantia nigra, which is a part of the mesoencephalon. They do not belong to telencephalon, but functionally they are related in the basal ganglia. Also notice that caudate nucleus, which is a comma-shaped nucleus, will have one amygdaloid nucleus at the anterior tail end, and that amygdaloid nucleus is also a component of basal ganglia, part of the telencephalon, hence structural nucleus. So we have 4 structural nuclei here mentioned and 2 functional, though there are numerous others as well. Basal ganglia is concerned with the planning and programming of the voluntary motor activity so that you can have smoothing of the activity. And if there is a problem of the basal ganglia, if there is a disorder, then there could be purposeless involuntary movements, like there could be the tremors, which is having no purpose and you cannot control the tremors. Now here is one diagram which we have taken a coronal section of the brain to show various nuclei under the basal ganglia. You will see there is a midline ventricle, which is a third ventricle sandwiched between the 2 thalami. And in relation to that, you can see several nuclei which are part of the basal ganglia. This is the caudate nucleus, which you can see, and then there is a lentiform nucleus. The lentiform nucleus is showing the 2 parts. There is an outer putamen and inner globus pallidus. So this is the lentiform nucleus with 2 components, and then you can also see there is the nucleus under thalamus, which is subthalamic nucleus, part of diencephalon. And then you can see substantia nigra, which is present in the midbrain, making some neurotransmitter called dopamine. So that dopamine is required for a pathway which is called as nigrostriatal pathway. Let us talk about that pathway now. But first you should know what is a striatum nucleus. And for striatum, you have to connect 2 of the things, that is caudate with the putamen. And when you say it is caudate plus putamen, it is called a striatum. Now, if that is the striatum, then what is putamen plus globus pallidus? That is called as the lentiform nucleus. So if it is the putamen plus the globus pallidus, it is lentiform nucleus, and if it is the putamen plus caudate, it is called striatum. Now here is the pathway which is called as the nigrostriatal pathway, coming from substantia nigra towards the striatum and using dopamine. Some patients may have less of dopamine and resulting in a lesion of the nigrostriatal pathway, and that is Parkinson's disease. In Parkinson's disease, you will find that the patient requires some L-DOPA, and along with that you can also give anticholinergics like trihexyphenidyl. Now, why are you adding trihexyphenidyl anticholinergic? Because in these patients, if you have less of dopamine, there is relatively increased acetylcholine. So you have to block the acetylcholine at the central level. And what are the clinical features the patient is having? The patient will be having tremors, rigidity, and hypokinesia. Now, before you look at a patient of Parkinson's, you can also see that what happens if there is a lesion of caudate nucleus. There could be chorea. And what if there is a lesion of the lentiform nucleus, like in a copper metabolism disorder, Wilson's disease? Wilson's disease, which is actually a problem of the lentiform nucleus, the patient will develop some purposeless involuntary movements. Then there is one condition called as the hemibellismus, and hemibellismus is a problem due to a lesion in the subthalamic nucleus, hemibellismus. So these are all going to give us purposeless involuntary movement, and they are all basal ganglia disorder. Let us talk more about the Parkinson's disease patient now. This is the case of Parkinson's disease, and the patient is having tremors, rigidity, and hypokinesia. Tremors are typical pill rolling tremors, and there will be composite movements at multiple joints. There will be a rigidity also, which could be continuous resistance to the passive movements, that is lead pipe rigidity, or there could be intermittent resistance, which is called as cogwheel type of rigidity. Now, as you say, there are tremors, and there is rigidity. There is also what is called as hypokinesia. There is less of movement. You can observe the patient will have mask-like faces, no facial expression. Plus, there is paucity of the movement. The patient is unable to start a movement, and once the movement is started, unable to stop the movement. They will have some slow shuffling gait as well. Now, extrapyramidal system is basically working for the pyramidal system, which is meant to move the skeletal muscles. And how do you move the skeletal muscles? We are taking one example. We are asking a patient to put a thread into needle. For that, the patient needs to look at the eye of the needle, and that will require the movement of the eyeball, corticonuclear tract. And when he is putting a thread into the needle, then will be corticospinal tract. Now, corticonuclear tract to move the eye, or corticospinal tract to move the finger together is pyramidal system. So pyramidal system is basically corticonuclear tract plus corticospinal tract, and it is required for fine and skilled voluntary motor activity. For example, putting a thread into needle. But before you do that, you must use extrapyramidal system. And what is the function of extrapyramidal system? Like basal ganglia, it is for planning and programming of the voluntary motor activity. You must plan that the needle should go into your left hand and the thread should go into your right hand, because you are right-handed person. So who is deciding thread should be in right hand or needle should be in left hand? That is done by extrapyramidal system, so that the pyramidal system can perform it properly. So planning and programming of voluntary motor activity, whereas the execution itself is done by pyramidal system, having two components. Now, we want to know where are they passing through the internal capsule, because internal capsule, some collection of axons will be sandwiched between the various parts of basal ganglia. In fact, the corticonuclear tract will pass through the genu of the internal capsule, and corticospinal tract will be passing through posterior limb of the internal capsule. So we want to look at the diagram now. This is a transverse section of the brain, and you are removing the upper part of brain so that you can have superior view of the brain. Now, if this is a superior view, that will be anterior, this will be posterior, this is the right side of the body. And you can see this is right-sided internal capsule we are going to talk about. But first, let us mark the parts of basal ganglia. And before that, you can show the thalamus on each side. Now, if you say this is the thalamus on each side, it is understood that sandwich between the two thalami is the third ventricle in the midline. So that is the third ventricle in the midline. We have learned that third ventricle is having the pineal gland posterior. So this is the pineal gland posterior, and it is having the fornix anterior. Though we understand that fornix is not only anterior to the third ventricle, it is at the roof of the third ventricle because it is a C-shaped structure, but partly comes anterior as well. And these are the lateral ventricles on either side. They are communicating with the third ventricle through foramen of Monro, which you can mark here. So these are the lateral ventricles, and they are going to communicate with the third ventricle by this foramen of Monro there. Now this foramen Monro lets the CSF from the lateral ventricle into the third ventricle, which is the midline ventricle, and between the two lateral ventricles is the septum pellucidum attaching to the fornix and also corpus callosum. We are marking the corpus callosum here, which is more anterior, and you are also marking septum pellucidum, which is between the corpus callosum and the fornix anterior. Here is the septum pellucidum, which is between the two lateral ventricles and attaching to the corpus callosum and the fornix as well. The lateral ventricles come throughout the cerebrum, so they can be seen posteriorly also. This will be the posterior horn or the occipital horn of the lateral ventricle. So here is the lateral ventricle coming posteriorly, and that is the occipital horn or posterior horn of the lateral ventricle on this side. Now let us mark the basal ganglia components here. This is the anteriorly placed caudate nucleus, the head of the caudate nucleus on either side. And this is the lens-shaped lentiform nucleus, which is posteriorly present. Lentiform nucleus will have an outer, which is called as the putamen component, and there is a medial, which is globus pallidus component. Globus pallidus itself will have some external, internal areas as well. And then you can see some collection of the axons which are arranged in a V-shaped fashion called internal capsule. If you remember, we have discussed that internal capsule is some collection of axons, which is projection fiber projecting from upper brain center to lower brain center and separating caudate nucleus medial and lentiform nucleus lateral. So that internal capsule is the anterior limb of the internal capsule. And then you can notice there is a posterior limb of the internal capsule as well, and that is a bend which is called as the genu. You can notice the posterior limb of internal capsule is sandwiched between lentiform lateral and the thalamus medial. So this is the superior view of the brain and transverse section, the right half of the brain, and this is right-sided internal capsule with some basal nuclei. You notice that more laterally is the lentiform nucleus here, and which you can show there as well. This is the lentiform nucleus, which is having two components. If you are talking about the outer, then it is the putamen, and if you are talking about the inner, then it is globus pallidus. Then we can notice the head of the caudate nucleus anterior here as well as there. So head of the caudate nucleus anterior, and sandwiched between the head of the caudate nucleus and lentiform is the anterior limb of the internal capsule here as well as there. Internal capsule we are showing here, it will have anterior limb and posterior limb, and there's a bend which is called genu. Let us look at the genu as well. That is going to be the genu part of the internal capsule. And this is the anterior limb of internal capsule, that is the posterior limb. Let us see what is posterior limb sandwiched between lentiform laterally and thalamus medially. So here we got the thalamus, which is on the medial aspect of the posterior limb on the both of the diagrams. So this is the thalamus, which is medial, and this is the posterior limb of internal capsule, which is sandwiched between lentiform lateral and the thalamus medial. Now understand, corticonuclear tract is controlling the head muscles, and that is eyeball muscles passing through genu, part of the internal capsule. Corticonuclear tract, which is also called corticobulbar tract, to control the skeletal muscle of the eyeball and part of the pyramidal system, past the genu of the internal capsule, whereas the corticospinal tract, which will control upper limb muscle, trunk, and the lower limb muscle, will be passing the posterior limb of the internal capsule. So here we have got the corticospinal tract, the upper limb, trunk, and the lower limb area passing the posterior limb of internal capsule. You can see it is like homunculus. The body is arranged. More anteriorly is the head, then upper limb, then the trunk, and then the lower limb area. Then you notice there is a metathalamus and having two bodies. There is a medial geniculate body for music pathway, the auditory pathway, and there is a lateral geniculate body for the light pathway, visual pathway. These two are the metathalamus, and you will see that they are having auditory radiation and the optic radiation to discuss now. You will notice that auditory radiation is using the posterior limb of the internal capsule, which is called as the sublentiform fibers of the internal capsule, because they pass under the lentiform nucleus to reach the superior temporal gyrus, which is also called as Hassel's gyrus, area number 41-42. So this auditory radiation is the sublentiform fibers of the internal capsule there in the posterior limb of internal capsule. And then you can notice that the lateral geniculate body is sending fibers towards the calcarine sulcus called geniculo-calcarine tract, or the optic radiation. That is also passing through the posterior part of internal capsule and behind the lentiform nucleus. So we call it as retro-lentiform fibers of the internal capsule, carrying the visual pathway towards the calcarine sulcus. And there is some white lines of Janari and the striate cortex, occipital visual cortex, geniculo-calcarine tract, the optic radiation. You can see that here as well. This is the optic radiation we are talking about, and this is going to reach the occipital visual cortex, having some striations of Janari, and this optic radiation is passing behind the lateral ventricle posteriorly here, you can notice. Now, as we talk about the auditory pathway, let us remember a mnemonic SLIM 41-42. What is this SLIM 41-42? S is the superior olivary nucleus, L is the lateral lemniscus, I is the inferior colliculus, and M is the medial geniculate body. And you can understand it is a Brodmann number 41-42, superior temporal gyrus. Now, let us look at one diagram for the auditory pathway. So here you will notice that the S is superior olivary nucleus, the L is lateral lemniscus, and the I is inferior colliculus, and the M is medial geniculate body. Area number 41-42 is superior temporal gyrus. Now, the end organ of hearing in the inner ear is organ of Corti. From there comes a cochlear nerve, which is in a spiral ganglion. Because cochlea is spiral, the ganglion is called spiral ganglion, and it is bipolar neuron. The peripheral process towards the inner hair cell, and the central process towards the pontomedullary junction. There you will have the cochlear nuclei. Pontomedullary junction. So the first order neuron is in the spiral ganglion or the cochlear ganglion, and in the cochlea part of the inner ear. Now this is the first order neuron. What about the second order neuron? You will notice that 95% of the fibers are crossing the midline in the trapezoid body and reach the superior olivary nucleus on the other side. And from there begins the lateral lemniscus. Here is the lateral lemniscus, which is going to reach the midbrain inferior colliculus. And from there, you are going to reach the inferior colliculus to medial geniculate body. And from the medial geniculate body, we are using the sublentiform fibers of the internal capsule in the posterior part of internal capsule to reach the superior temporal gyrus. Area number 41-42, that is temporal auditory cortex. Now, talking about the visual pathway, let us look at the structure of the retina. In the retina, we will see that there is the first order neuron, the rods and cones. The second order neuron it is synapsing with is bipolar neurons, and bipolar will synapse the third order neuron, which is ganglion cell neuron, whose axons will then be making the optic nerve. So optic nerve is a third order neuron axons. Let us look at some detailed structure of the retina, which has actually 10 layers. The light falls from there, and this is the rod and cones, the layer number 4. And then you have to look at layer number 6. So as you see, layer number 8 as well. So layer number 4, as you see, is having some outer nuclear layer, which is rod and cones nuclei. Layer number 6 is the bipolar neuron nuclei, and layer number 8 is the ganglion cell neuron nuclei. You will see that there are some plexiform layers also, like this is between 4 and 6 you have the outer plexiform layer, and between the 6 and 8 you have inner plexiform layer. Then you'll notice that the third order neuron, which is ganglion cell, is sending some axons making the optic nerve. So these are the fibers of the optic nerve. And the last layer, 10th layer, is the inner limiting membrane. And the very first layer is the retinal pigment layer. So there are total 10 layers, and we have numbered some of them. Number 1, we have told it is retinal pigment layer. Then we have told about number 4, the outer nuclear layer, nuclei of the rods and the cones. And then we have talked about the outer plexiform, inner plexiform. But between the two layers, you have the inner nuclear layer, which is bipolar. And then there is one ganglion cell layer, which was the layer number 8. Then we have talked about layer number 10, which is the inner limiting, because between them was the optic nerve. Axons, that is layer number 9. Now we are looking at the superior view of a person who is lying here, and this will be the nose anterior, and that is the right ear to this side. So that this is the superior view of the right eye and the left eye. Now, as you understand, the peripheral vision is coming from the temporal aspect, the temporal or peripheral vision of the left eye. Let us follow that. So this is the temporal vision of the left eye, which will be coming to the nasal retina, and it will be crossing in the optic chiasma, the midline. As it crosses the midline in optic chiasma, it will be coming to the other sided lateral geniculate body, and from there it will go to the occipital visual cortex on the right side. So this is the right-sided occipital cortex and receiving the information of the left temporal vision. Whereas if you look at the right eye nasal vision, it will come to the temporal retina and continue on the same side of the brain. So here we follow the right nasal vision, and this right nasal vision is coming to the temporal retina and stays on the same side of the midline to reach the lateral geniculate body. And from the lateral geniculate body, it will reach the same sided occipital visual cortex. It means that the left half of each eye, the visual field comes to the right side of the brain. And if we have a lesion here, then left half of each eye will become blind. Like you can see, here is a lesion shown, which is maybe due to a block in the right-sided posterior cerebral artery, and that will result in left half of each eye becoming blind. Now, when you say left half of each eye is blind, it is called contralateral homonymous hemianopia with the macular sparing. Central vision is working. Why the central vision is working? Because the occipital visual cortex has additional supply from middle cerebral artery. Maybe the posterior cerebral artery was blocked, leading to contralateral homonymous hemianopia, but then there is a sparing of the central vision. You can see here this patient is having a problem with the nasal half of the right side. The vision is lost, and temporal half of the left side vision is lost. So left visual field is gone. This patient cannot see the things which are on the left visual field, called as contralateral homonymous hemianopia. And what happens if the lesion is in the optic nerve? If the lesion is the optic nerve, then this eye will lose the vision. So you can see right eye will have blindness. And what if the lesion is here? If the lesion is here, like it can be a midline tumor, like pituitary tumor, and result in bitemporal hemianopia. Tunnel vision, peripheral vision is lost. So here you can see that the temporal vision of right eye, temporal vision of left eye lost, and the bitemporal hemianopia, the tunnel vision in a pituitary tumor. And what if the lesion is in the optic tract? It is same as the lesion in the optic radiation, that there will be a contralateral homonymous hemianopia, and the left half of each eye will be blind. Left visual field will be lost. Patient cannot see the things which are on the left side of the body. Presently, we are looking at the details of cerebellum, and cerebellum is concerned with the coordination of the voluntary motor activity, and it is also concerned with the maintenance of posture and equilibrium and the tone of the body. Sometimes, if there's a lesion, there could be hypotonia found in the patient, and there could be incoordination leading to what is called as past pointing, or what is called as the intention tremors as well. And these patients, because there's a problem with the equilibrium posture, they start walking with the wide base gait, and you will see that some tests are also going to become positive. Now, talking about cerebellum, it will have a cerebellar hemisphere on either side, and it is a part of the metaencephalon along with the pons. If you talk about the pons, this is the pons, and that is connected to the cerebellum by the middle cerebellar peduncle. The middle cerebellar peduncle will be carrying pontocerebellar tract. Here you can notice the midbrain as well as the medulla oblongata, and this is the brainstem. Brainstem, which is the midbrain, pons, and medulla oblongata, is connected to the cerebellar hemisphere by the peduncles. If you connect the midbrain, it is superior cerebellar peduncle. If you connect with pons, middle cerebellar peduncle, and if you connect with medulla oblongata, inferior cerebellar peduncle. Let us see what are the fibers passing in these peduncles now. Also notice that these are the two thalami, and they are sandwiching the third ventricle in the midline. And this is the highest brain, that is the cerebrum. Now we want to magnify this area and look at the four deep nuclei, deep cerebellar nuclei, and then we'll also focus upon the cerebellar cortex, which is having 3 layers. In the 3 layers, there'll be total 5 cells. But first, look at the 4 deep cerebellar nuclei. The most medial is the fastigial nucleus, and it is near the midline. We can notice the most lateral is the dentate nucleus, which is teeth-shaped nucleus. So lateral most is the dentate nucleus, and middle most is the fastigial nucleus. Interposed nuclei are the globose and the emboliform, and together they are called the interpositus nucleus. And in the beginning, we were fish. Then we became reptile amphibians, and now we are mammals. So we have got this fastigial nucleus from the fish, and the interposition, which is the emboliform globose, from the reptile amphibians, and now the mammalian nucleus is the dentate nucleus. Evolution-wise, the latest is the lateral most, and oldest is the middle most. And this fastigial nucleus is important for saccadic eye movement as well. Now let us magnify the cerebellar cortex area, where you'll have 3 layers and total 5 cells. In this particular diagram of the cerebellar cortex, we have magnified this area here, and then we have magnified this area here. So in the beginning, you will see that this is the outer molecular layer, outer molecular layer, outer molecular layer. And then there is a middle Purkinje layer, middle Purkinje layer, and middle Purkinje layer. And then there is a inner granular layer, the inner granular layer, and this is the inner granular layer. So outer is molecular, middle is Purkinje, inner is granular layer. So total there are 3 layers in the cerebellar cortex and total 5 cells. In the outer, which is the molecular layer, you'll have 2 cells, namely the stellate and the basket cell. In the middle, it will be the Purkinje cell layer. And the inner, deeper one is the granule cell layer, where you have the GG cell, granule, and Golgi cell, inner granular layer. Now let us magnify this part of the diagram. you will notice that there is a molecular layer which is the outer, and there is a middle layer which is Purkinje, and there is a deeper layer which is the granule layer. In the molecular layer, you will see two types of cells, the ciliate and the basket cells. And in the Purkinje layer, you see Purkinje cell. These are the nuclei of the Purkinje cell, and you will see their processes are going towards the outer molecular layer. So that is the identification that molecular layer is towards the outer side, and it is having less of the nuclei, whereas the inner granular layer, which is having the GG cell, the granule and Golgi cells, are having multiple dense distribution of the nuclei. This is all cerebellar cortex, 3 layers and 5 cells. A question comes that there are 5 cells in the cerebellar cortex, which is the only cell which can send the information out, the only efferent from the cerebellar cortex, and the answer is Purkinje is the only outgoing fibers, the efferent fibers, and it uses GABA, gamma-aminobutyric acid, and that will be neuroinhibitory transmitter. So what is it going to inhibit? The deep cerebellar nuclei, especially the dentate nucleus. Now here we are telling this person to walk in a straight line, and he has moved his right lower limb. So there's a change of position of the right lower limb, and it is proprioception. That proprioception will be carried by the right-sided dorsal spinocerebellar tract towards the right-sided cerebellum, which will process the information and send it across the midline to the thalamus on the left side to the left cerebrum. Then let us look at the pathway now. So this is the right-sided dorsal spinocerebellar tract carrying the proprioception or position sense of the right lower limb, and it uses the inferior cerebellar peduncle to reach the cerebellum. In the cerebellum, it will be synapsing with the granule cell, and granule cell will be communicating with the other 4 cells of cerebellar cortex, which will then communicate with the Purkinje and the dentate nucleus. The dentate nucleus, which is receiving inhibitory signals from the Purkinje, will send a dentatothalamic tract across the midline of the body. This dentatothalamic tract is passing through red nucleus of the midbrain, so full name is dentatorubrophthalamic tract, and it uses superior cerebellar peduncle. Now this thalamus is communicating with the left cerebral cortex, and thus the left cerebral cortex will know the position of the right lower limb, which is processed by the right cerebellum and sent towards the left cerebrum. It is the left cerebrum which is then sending the pyramidal tract, corticospinal tract, so that it can move the right lower limb accordingly. This pathway is important for coordination of voluntary motor activity and walking in a straight line, which can be lost if you have a lesion here, lateral medullary ischemia, Wallenberg syndrome, spinocerebellar tract is compromised, and there is ischemia of the lateral medulla, inferior peduncle, and the proprioception is compromised. There will be a right-sided cerebellar ataxia. Patient cannot walk in a straight line and keep falling to the same side, and the heel shin test will become positive on the same side. So normally, the position sense of the right lower limb processed by the right cerebellum should reach the left cerebrum, and the left cerebrum should send the pyramidal tract to move the right lower limb accordingly. So here is the pathway which is called as the corticospinal tract crossing in the lower medulla oblongata, and then it is running through the spinal cord and can control the movement of the right lower limb. Let us look at these pathways once again. As we said, the right lower limb was changing the position sense. There was a right-sided dorsal spinocerebellar tract activated, and which was passing through the inferior cerebellar peduncle. That is going to make mossy fibers. As you can see here, this is the right-sided dorsal spinocerebellar tract and making the mossy fibers. And those mossy fibers are going to synapse with the granule cell in the cerebellar cortex. Now, this granule cell will have some parallel fibers, and using parallel fibers, it will communicate with the remaining 4 cells in the cerebellar cortex. Ultimately, all the 5 cells of cerebellar cortex will know the position sense of the right lower limb. But out of 5, only 1 cell has the capacity to send the information further, which is the Purkinje cell. And Purkinje cell, which is the only output tract from the cerebellar cortex, will be using GABA on the deep cerebellar nucleus, which is dentate nucleus there, sending dentatorubrophthalamic tract using superior cerebellar peduncle crossing the midline of the body. So here is the dentato-rubro-thalamic tract going towards the contralateral thalamus using superior cerebellar peduncle. In the inferior peduncle, you had the dorsal spinocerebellar tract. In the superior peduncle, you have dentato-rubro-thalamic tract passing. And then the thalamus is going to communicate with the cerebrum on the left side, and the cerebrum has the process information of the right lower limb position. It will then send the corticospinal tract, which is going to control the right lower limb. So this is the corticospinal tract, which is also called pyramidal tract, and which will be actually crossing in the lower medulla and then control the right lower limb. Coordination of voluntary motor activity. Now, it is understood that cerebellum communicate with the cerebrum, and cerebrum will also like to communicate with cerebellum, and there will be a feedback mechanism. That feedback mechanism, you will call it as CPC tract, that is cortico-pontocerebellar tract, and this cortico-pontocerebellar tract is using middle cerebellar peduncle. As we said, middle cerebellar peduncle has pontocerebellar tract. So this is the feedback mechanism, cerebellum talking with cerebrum and cerebrum talking with cerebellum. Now, this is kind of a repeat information here. As we said, the patient was moving right lower limb, and as the right lower limb is moved, there is a dorsal spinocerebellar tract which was making the mossy fibers and passing through inferior cerebellar peduncle to reach the granule cell in the cerebellar cortex. And this granule cell in the cerebellar cortex will have some parallel fibers. Using those parallel fibers, it is going to communicate with the remaining 4 cells of the cerebellar cortex, which is outer layer, Steele-Wren basket, and the inner layer, which is the Golgi cell, and the middle, which is the Purkinje cell. Now, all the 5 cells have the information of the position sense of the right lower limb. But out of 5, only 1 cell has the capacity to send the information further towards the deep cerebellar nuclei, and that is the Purkinje cell. So this Purkinje cell is sending the information towards the deep cerebellar nuclei like the dentate nucleus. So these deep cerebellar nuclei like dentate nucleus will be inhibited because it is Purkinje cell using gamma aminobutyric acid neuroinhibitory transmitter. And from there, the next pathway will begin, which is going towards the contralateral thalamus. This is called dentato-rubro-thalamic tract using superior cerebellar peduncle. You should also know that there is an olive in the medulla. Deep to that is inferior olive nucleus, and from the inferior olive nucleus comes the climbing fibers, and these climbing fibers will climb towards the Purkinje cell. So climbing fibers are coming from the medulla using inferior cerebellar peduncle and olivocerebellar tract communicating with Purkinje cell in the cerebellar cortex. So there are 2 types of fibers coming to the cerebellum. One is the mossy fibers, which is the dorsal spinocerebellar tract using inferior cerebellar peduncle, and the other is the olivocerebellar tract, which is also using the inferior cerebellar peduncle, the climbing fibers climbing to the Purkinje cell in the cerebellar cortex. So in cerebellar lesions, the position sense of the lower limb is compromised. Heel shin test vehicle positive. You are asking the patient to move his heel straight on the shin, which he is unable to. The heel goes zigzag, zigzag. And these patients start walking with a wide base gait because they have a tendency to fall through the same side of lesion, cerebellar ataxia. Let us look at some tracts passing through the spinal cord, and actually we got a patient who has a right-sided hemisection of the spinal cord, and that is actually at the level of thoracic 10, and as you see, the patient is having most of the clinical features on the same side. There will be paralysis on the same side and loss of some sensation on the same side, but then there is loss of pain, temperature, crude sensation on the contralateral side. Since these sensations are carried by spinothalamic tract, which is running contralateral, the problems will be contralateral. So as we are looking at the hemisection of the spinal cord, you'll see there is a problem with the dorsal column in the spinal cord. And as the dorsal column is compromised, you will see 5 sensations carried by the dorsal column will be lost on the same side of the lesion. And those sensations could be tactile discrimination, vibration, proprioception, etc. When we are talking about the spinothalamic tract, we will find the spinothalamic tract is running contralateral. That is why the problems will appear on the opposite side of the lesion, loss of pain temperature and crude sensation. And as we discuss the corticospinal tract injury, which is pyramidal tract injury, you will see there will be a spastic paralysis, but below the level of the lesion. Why not at the level of lesion? Why there is a flaccid paralysis at the T10 muscle level? There is a flaccid paralysis at the T10 muscle level because of the injury of lower motor neurons. So there is some injury of the lower motor neurons here, and which control the skeletal muscles, and they have been compromised, leading to flaccid paralysis only at the level of the lesion. Below the level of lesion, there is spastic paralysis. Now let us have a look at the transverse section of the spinal cord and talking about the various tracts which we have just discussed. There's a dorsal column which is carrying the position, sense, vibration, pressure, having two fasciculi. There's a medial fasciculus gracilis, lateral is cuneatus, and they are carrying some 5 sensations, like that is the pressure, touch, vibration, and the stenosis and conscious proprioception also, which will be lost on the same side of the lesion if it was a Brown-Séquard syndrome. Then we have talked about the anterior and lateral spinothalamic tract. Actually, if it is spinothalamic tract, it is contralateral, so there will be contralateral problems. If the lesion is on the right side, the problems will come on the left side. Remember, the lateral tract carry pain and temperature from the opposite side of body, and the anterior spinothalamic tract is carrying pressure and touch. Though touch and pressure is already carried by dorsal column, the anterior spinothalamic tract will have some minor role as it is carrying the light touch and the crude touch sensation, whereas the dorsal column is DDD, means the dorsal column carry the deeper touch and the discriminatory touch, like 2-point discrimination carried by the dorsal column. Also understand that there will be a lesion of the dorsal spinocerebellar tract in the Brown-Séquard syndrome. So there will be a cerebellar ataxia. The heel shin test will become positive on the same side of the lesion, and patient keep falling to the same side of the lesion. We will also be talking about the corticospinal tract, the pyramidal tract, which they have shown on this side. And remember, this corticospinal tract on the pyramidal tract is, if compromised, then there will be spastic paralysis, but below the level of the lesion. At the level of lesion, there will be flaccid paralysis because there some anterior horn cells have been compromised. So T10 muscles will be flaccid, but T11, 12, L1, 2, S2, below the level of lesion, there will be spastic paralysis. Let us talk more about the pyramidal tract now in the next diagram. Pyramidal tract has two components. There is a corticonuclear tract, there is a corticospinal tract, like you are putting a thread into needle. If you want to look at the eye of the needle, corticonuclear tract is required, and to move your finger, corticospinal tract is required. Fine and skilled voluntary motor activity, the function of pyramidal tract. There is some upper motor neuron at the upper level, that is the cerebrum, and it is going to control the lower motor neurons which are in the brainstem or spinal cord. These cranial nerves or the spinal nerves control the skeletal muscles, and that is modulated by the upper motor neuron. First, the upper motor neuron will activate the lower motor neuron to move the skeletal muscles, and then it has to inhibit also. So it is stimulatory as well as inhibitory, means it is modulatory. It is positive as well as negative. Now, if it may happen that the upper motor neuron fibers have been compromised, then the lower motor neuron will become free to fire frequently, and they take the muscle into spasm. There will be spastic paralysis. On the other hand, if I have injury to the lower motor neuron, then the muscles will not be working. They will go into flaccid paralysis. So LMN lesion leads to flaccid paralysis. Like in polio virus, there is a lesion of the lower motor neuron, anterior horn cell, and the muscle will go into the flaccid paralysis. Now here we are showing the corticonuclear tract, which is also called corticobulbar tract, and there's a corticospinal tract as well. This is the homunculus. We understand that the lower lateral cerebrum is for the face area, higher is the upper limb area, where the lower limb, pelvis perineum, is on the medial side of the cerebrum. If you want to move the eye muscles, then you have to use the corticonuclear tract, which is also called corticobulbar tract, passing genu of the internal capsule and then crossing at the level of the motor nuclei. The lower motor neurons fibers are coming from here, that is the cranial nerves, and that could be cranial number 3, 4, 6, or any of the motor nerves. Similarly, if I want to move my fingers, then I'll have a corticospinal tract which is crossing in the lower medulla, pyramidal decussation, and then the synapsing on the spinal cord. There's a lower motor neuron. And from there come the spinal nerve, and that could be radial nerve, ulnar nerve, and controlling some of the skeletal muscles. This corticospinal tract is passing through the posterior limb of the internal capsule, then reaching the lower medulla, decussating, and then synapsing at the anterior horn cell of the spinal cord. And from there comes the spinal nerves. Now understand that if I have a lesion of the genu of the internal capsule on the left side, then it is the muscles of the right face which will be compromised, and that also the lower face muscles. But why only lower face muscle? Why not upper? Because this is UMN type of palsy, and this is going to be compromised lower face muscles. Let us look at that detail now. Understand that if there is a lesion in the genu of internal capsule on the left side, it is the lower half of the right face which will be compromised. Now, it is to be understood that lower half of the face muscle, like orbicularis oris, will be a dribbling of saliva. The lower face muscles are controlled only by contralateral cerebrum. So that's why they were compromised. But why the upper face muscles like orbicularis oculi are still working? Because they have bilateral innervation. Upper face muscles have bilateral innervation. Maybe the left-sided tract has been compromised, but the right-sided tract is still working. So as you see, this is the right-sided corticonuclear tract which is controlling the upper face muscle, and upper face muscles are still intact. They are still working, like orbicularis oculi is still working. But understand, if it is infranuclear palsy, like below the level of nucleus, facial nerve injury like Bell's palsy, there is a viral inflammation, then it is the upper face and lower face both are compromised, and it is on the same side. So this is element type of facial palsy, the Bell's palsy. It is a ipsilateral problem, and both the upper and lower half face compromised. Whereas that is UMN type of facial palsy. The problem will be coming contralateral, and only lower face muscle will be paralyzed. Upper face will be spared because upper face has bilateral representation and still being controlled by this side of the brain. Maybe that side of the brain is compromised, fibers, but this side of the brain is still intact. Now we are looking at a patient who is lying here in the CT scan machine, and the nose is anterior, and this is the left side of the body. You have taken a CT scan from inferior view, you are looking at that. So in the CT scan, that will be anterior, and this will be the left-sided body. There is a lesion in the left-sided internal capsule, the genu as well as the posterior limb of internal capsule. Genu has the corticonuclear tract passing, and the posterior limb has the corticospinal tract passing, and they have been compromised. If the lesion is on the left internal capsule, the problem will come on the right side, and this patient will have right-sided lower face muscles compromised, and also there will be hemiparesis, hemianesthesia, hemiplegia on the right side. The patient will come to you like this. There is a lesion on the left-sided internal capsule, and the right-sided lower face muscle have been compromised, dribbling of saliva. And then you will see there is a flexion deformity in the upper limb and extension deformity in the lower limb. It happens because in the upper limb, flexors are more powerful than extensors, and in the lower limb, the extensors are more powerful than the flexors. So lower limb in extension deformity, upper limb in flexion deformity, and there will be a circumduction gait. It is contralateral spastic paralysis. If the lesion was on the left, problem is on the right side of the body. And also understand that in the posterior limb of internal capsule, carrying the fibers of dorsal column, medial lemniscal system, and also spinothalamic tract. So that is why the patient will have problems of sensation on the body. There will be loss of touch pain, temperature, pressure on the body. Now let us look at some more details of the fasciculus cuneatus and gracilis, that is the dorsal column of the spinal cord, the pathway. You will notice that the first order neuron is the dorsal root ganglion, and which is giving us fasciculus cuneatus gracilis, which run ipsilaterally. So dorsal column runs ipsilaterally. First order neuron is the dorsal root ganglion, and as you see, there could be a Pacinian corpuscle carrying the pressure, or there'll be a mesolar corpuscle which is carrying the tactile discrimination, and the dorsal root ganglion is the first order neuron. You will see that the fibers are running ipsilateral in the dorsal column. The second order neuron will be in the medulla oblongata, which is nucleus cuneatus and nucleus gracilis. Now, the second order neuron, which is the nucleus gracilis and nucleus cuneatus, will be crossing the fibers, and that is running as the second order neuron, which is the medial lemniscus. Here, crossing the midline and running as the medial lemniscus, going to the third order neuron, which is the thalamus. Thalamus, it is the ventro-posterior-lateral nucleus of the thalamus. And the thalamus, which has the third order neuron, will be using posterior limb of the internal capsule to send the fibers towards the cerebral cortex, area number 1, 2, 3. So here is the third order neuron, and that is the third order neuron. As you understand, the third order neuron will be passing posterior limb of the internal capsule to reach the cerebral cortex, and it is also the sensory homunculus that the lower limb is on the medial side of cerebrum, and then the upper limb and the face is lower and lateral aspect. Now understand, if there is a Brown-Séquard syndrome, hemisection of spinal cord, then all the sensations which are carried by dorsal column will be lost on the same side of the lesion. And as we talk about the anterolateral spinothalamic tract, which is carrying pain, temperature and crude sensation, let us look at the pathway now. The receptor is free nerve ending, and the first order neuron is the dorsal root ganglion. Now, if you say free nerve ending, the dorsal root ganglion is the first order neuron. Where is the second order neuron? It is a posterior horn cell in the spinal cord and crossing the midline of the body in spinal cord and running as the lateral spinothalamic tract. So, second order neuron, which is running contralateral here. This is the posterior horn cell, which is sending the crossing fiber anterior white commissure and running as the lateral spinothalamic tract to reach the thalamus, the third order neuron in the thalamus. This second order neuron is called as the lateral spinothalamic tract. As it passes the brainstem, it is called spinal lemniscus. And then the thalamus will give the third order neuron, which will be using the posterior limb of the internal capsule and reaching the cerebral cortex, parietal sensory cortex, area number 1, 2, 3, there. You can see here also that thalamus is giving the third order neuron, which is passing the posterior limb of internal capsule, reaching the cerebral cortex, parietal sensory cortex, area number 1, 2, 3, post-central gyrus. So this is the spinothalamic tract, spinal lemniscal system. If it is compromised in the Brown-Séquard syndrome, say right-sided Brown-Séquard syndrome, the problem of loss of pain temperature will be on the left side of the body, contralateral loss of pain temperature in the body. So here is our patient. We have loss of pain temperature in the body, but it is on the opposite side of the lesion. Lesion is on the right side of the spinal cord T10, but the problem appears on the left side. And this happens because of a tract compromise, namely the lateral spinothalamic tract there. And since there is a injury of the fasciculus cuneatus and gracilis, the dorsal column, on this side, there will be loss of phi sensation on the same side of the lesion, which is loss of the pressure, vibration, tactile discrimination, etc. on the same side of the lesion, injury of the dorsal column. And since the pyramidal tract has been compromised on this side of the body, you'll see there will be a spastic paralysis on the same side of the lesion, and that is below the level of the lesion. All the lower motor neurons become free to fire frequently, and there'll be spastic paralysis, but not at the level of lesion. Why not at the level of lesion? Why the T10 muscles are in flaccid paralysis? Because there, the lower motor neurons have been compromised. You will see that since the lower motor neuron have been compromised at the T10 spinal segment, there will be flaccid paralysis only at the T10 muscle level. And since there is a lesion of the spinocerebellar tract, there will be a cerebellar ataxia on the same side of the lesion. Patient keep falling to the same side. Heel shin test will become positive on the same side of the lesion. Here we are looking at a case of right-sided Weber syndrome. And what we find is that most of the problems in the body is on the left side. So the problems come on the left side, but there is one problem on the right side, that the oculomotor nerve feature, that is the down and out eye and fixed dilated pupil, will be on the same side of the lesion. And why is that so? You see, there is ischemia in the anterior midbrain, and there is a problem of the third nerve on the same side. This is the oculomotor nucleus sending the oculomotor nerve, which has been compromised. As this is the lower motor neuron for the third nerve and it is the element palsy for the third nerve, the problems come on the same side. But for the other nerves like number 5, 7, 12, or for the spinal nerves like radial nerve and the ulnar nerve, they'll be contralateral. Why? Because these nerves are passing in the pyramidal tract, and that pyramidal tract has been compromised on right side before they have crossed to the other side and supplying the muscle on the other side of the body. So since the pyramidal tract is compromised on this side, the problems will come on the other side of the body. You will see there will be corticospinal tract compromise, so spastic paralysis in the body, and there will be corticonuclear tract compromise. So number 5, 7, 12 paralysis will be on this side. You can also notice that there is a lesion of the substantia nigra on this side. So there will be a feature of Parkinsonism, but on the contralateral side. Let us take a transverse section of the midbrain here to discuss it further. As you take a transverse section of the midbrain here, we'll be looking at the details now in the next diagram. In this diagram, you can see we have taken a section at the level of the superior colliculus here. That is where you will find the third nerve nucleus. So this is going to be the third nerve nucleus, and it is around this cerebral aqueduct in the periaqueductal gray. So there is a periaqueductal gray around the aqueduct of the sylvius, and from there comes the third nerve out. The third nerve out, and somehow that third nerve, which is lower motor neuron for the third nerve, have been compromised. That is why there was a ipsilateral down and out eye, and there was a fixed and dilated pupil. But understand that this is the crus cerebri, where you have more medially corticonuclear tract passing, or laterally corticospinal tract passing. And since this crus cerebri has been compromised, there will be some fibers which are going to cross and control the muscle on the other side of the body. Those fibers have been compromised, and it is UMN fiber lesion. So there will be now number 5, now number 7, now number 12, or the radial nerve, ulnar nerve compromised on the other side of the midline. You can also notice that since it was an injury of the substantia nigra here, on this side, right side, there will be a contralateral features of Parkinsonism on the body. In fact, most of the problems will be coming on the opposite side of the lesion, except one, that the oculomotor nerve problems will be on the same side because it is element fiber injury for the third nerve. We need to understand that we have a corticonuclear tract which is going to cross at the level of the motor nuclei in the brainstem, so that the cranial nerves can go further and control the skeletal muscle. So this side of the cerebrum control the other side of the body. For example, number 5, number 7, number 12. Especially some of the muscles like lateral pterygoid, the trigeminal nerve, lower face muscles, facial nerve expression, and genioglossus muscle, that is supplied by 12th nerve. Remember, these muscles have only contralateral innervation. The muscles on this side of the body will be controlled from the other side of the cerebrum. And otherwise, most of the muscles here have bilateral representation, except the lower face muscle and the genioglossus and the lateral pterygoid, because they have only contralateral innervation. If we have a lesion at the level of the right midbrain, which is the Wright-Weber syndrome, we'll understand that there will be a contralateral paralysis of the muscle of the trigeminal, facial, and the genioglossus 12th nerve. And also understand that there is a corticospinal tract which is going to cross in the lower medulla so that it can control the lower motor neuron on the opposite side of the midline. And these are the one which control the skeletal muscle on this left side of the body. Now, since there was a right-sided Weber syndrome, and there is a injury of the crus cerebri. Not only corticonuclear tract was compromised, but corticospinal tract is also compromised on the right side, and there will be a spastic paralysis on the left side of the body, maybe upper limb, trunk, or lower limb region. So the lesion is on the right side Weber syndrome, but the problems are on the left side of the body, except for one nerve, which is oculomotor nerve. Since the oculomotor nerve is coming here, the lower motor neuron fibers, that was compromised. So for the third nerve, it is the same-sided down and out eye, fixed and dilated pupil in right-sided Weber syndrome. It is element injury of third nerve and human injury of nerve number 5, 7, 12, or the corticospinal tract. As we talk about the corticonuclear tract, and we are telling that it is to cross at the level of the motor nerve nuclei in the brainstem, so that you can send the nerve number 5, 7, 12 to control the skeletal muscles on opposite side of the body. You see, this is the corticonuclear tract, which is crossing for trigeminal nerve, and this is the trigeminal nerve, which is now going to control muscles like lateral pterygoid. And this is the corticonuclear tract, which is crossing at the level of the pons to control the muscles of the lower face, the facial nerve. And this is the corticonuclear tract crossing at the level of medulla to control the muscles of the tongue, the 12th nerve, genioglossus. Now, since the lesion is at the level of the midbrain, the crus cerebri, it is understood that right-sided Weber syndrome will lead to injury of upper motor neuron fibers, and there will be a problem of the 5th nerve and the problem of the 7th nerve and the 12th nerve muscles on the opposite side, especially the muscles which are called as lateral pterygoid or the lower face muscle or the genioglossus muscle. But since the third nerve nucleus has already given the lower motor neuron fibers and they were compromised in Weber syndrome, the third nerve problems will be ipsilateral and element type of palsy. So third nerve problems are ipsilateral element type of palsy, and number 5, 7, 12 are contralateral palsy. Why not the other nerves like 4 or the 6 or the 9, 10? Because you have to understand that most of the muscles have bilateral representation. Even if this pathway was compromised, this pathway is intact. So most of the muscles are still working, but not the muscles which are called as lateral pterygoid or the lower face muscle or the genioglossus, because these muscles are having only contralateral innervation. So they are typically, specifically paralyzed. So this was our case. At the level of the midbrain, there was some medial midbrain ischemia leading to Weber syndrome, and right-sided eye was down and out, fixed and dilated pupil, but the problems in the face and the body was contralateral. This is called alternating hemiplegia. The third nerve problem is on the same side of lesion, whereas the other problems are on the other side of the lesion. So alternating hemiplegia is a feature of Weber syndrome. Similarly, if the lesion was in the pons, you will see the 6th nerve will be compromised and there will be a medial squint. So it is the abducens nerve palsy, and there will be a medial squint because medial rectus became more powerful. LR6 has been compromised, lateral rectus is compromised. Similarly, if the lesion was at the medulla level, then the 12th nerve is compromised and the right half of the tongue muscle will be paralyzed there. But understand, the other problems will be contralateral. These are the examples of medial syndromes: medial midbrain, medial pons, or medial medulla syndrome. The problems will appear on the same side of the lesion for the respective nerve exiting at the level, but then the spastic paralysis will be contralateral. This is called as alternating hemiplegia. The problems of some nerves on this side, but other problems are on the opposite side of the body. We must understand that even if the ischemia was lateral, say for example in the lateral part of the pons, or maybe it is at the level of trigeminal nerve, or it is at the level of the facial nerve, or maybe in the medulla, like lateral medullary ischemia, which is also called Wellenberg syndrome, at the level of the nucleus ambiguus, which is the number 9, 10, 11. If it is injury of the trigeminal nerve, you will see that the trigeminal muscles like the lateral pterygoid will be compromised on the same side. In this case, it is lateral pontine syndrome, and this is also lateral pontine syndrome where the facial nerve has been compromised on the right side, and this is the lateral medullary syndrome, which is Wallenberg syndrome. You will see nucleus ambiguus has been compromised, shown on number 9, 10, 11 has been compromised on the right side, and there will be difficulty speech swallowing because the muscles of palate, pharynx, larynx will be compromised on this side. This is element lesion for nerve number 5, 7, and 9, 10, 11. Also understand that in these cases, there will be no spastic paralysis. Why? Because the spastic paralysis comes due to lesion of the pyramidal tract, and pyramidal tract run near the midline, and it has been spared. So if it is lateral brainstem ischemia, it will not be affecting the pyramidal tract, which is running near the medial aspect. So these patients do not present with contralateral spastic paralysis, but they do present with contralateral loss of sensations. So what kind of sensory loss will be there? It is the loss of pain and temperature, which is contralateral. And why is that so? Because there is a laterally running tract which is called as the spinothalamic tract, which has been compromised. So when the spinothalamic tract has been compromised, which is running more lateral, you will find that there is a loss of pain temperature on the opposite side of the body. But there is preservation of the 5 sensation carried by the dorsal column medial lemniscal system. Why is that so? Because the dorsal column medial lemniscal system runs near the midline, so it has not been compromised. In this case, the pyramidal tract and the dorsal column medial lemniscal system is not compromised. That is why there is no spastic paralysis or there is no loss of 5 sensation carried by dorsal column. Only there is loss of pain and temperature because the laterally running tract, which is called as spinothalamic tract, has been compromised. It will become more clear when we are talking about the Wallenberg syndrome or the lateral medullary syndrome in detail. So here is a case of right-sided Wallenberg syndrome, and there's a contralateral loss of pain temperature because the spinothalamic tract has been compromised on the right side. It runs more lateral, that is why there is a problem, pain and temperature of opposite side of the body. But there is no loss of the sensation which are carried by dorsal column medial lemniscal system. Now, why there is loss of pain temperature on the face on the same side? The loss of pain temperature on the face is same side because of injury to the spinal sensory nucleus of trigeminal. Spinal sensory nucleus of trigeminal carry pain temperature from the same side of the body, so it will be compromised on the same side, but the body pain temperature is contralateral. This is called alternating hemi-anesthesia, alternating loss of pain temperature on the same side of lesion but opposite side of the body. And this is a feature of the lateral medullary ischemia or Wallenberg syndrome. You will also notice some additional problems like ipsilateral Horner syndrome and ipsilateral cerebellar dystaxia. And why is that happening? Let us discuss that as well. For this purpose, we have to take a transverse section at the level of the medulla oblongata now. And this is our patient, and it is like a CT scan view. We are looking from inferior to superior, that is the nose anterior, and this is the left side of the body. The problem is on the right side of the body. So it is the right-sided Wallenberg syndrome, and there is some ischemia in this area. So some of the tracts have been compromised, and we want to talk about the clinical features then. Right-sided Wallenberg syndrome, right-sided clinical features, and some of them will appear on the left side as well. Now, why are we having ipsilateral Horner syndrome? Because there is injury of a tract here, which is called as the Horner pathway. We'll be talking about the Horner pathway in a short while, but if it is compromised, then there'll be a hypothalamo-spinal pathway compromise and leading to ipsilateral Horner syndrome, paralysis of the dilator pupillae and the superior tarsal muscle, leading to meiosis and ptosis on the same side of the lesion. And why there is ipsilateral loss of pain temperature on the face? Because of injury to this nucleus, which is called as the spinal sensory nucleus of trigeminal, which is carrying pain temperature from the same side of the face. If it is compromised, there's a loss of pain temperature on the face same side. Then why the body is having loss of pain temperature on the contralateral side? Because that is injury of spinothalamic tract, which runs contralateral. If you damage the spinothalamic tract on this side of the brain, then the problem on the body will be coming contralateral. That is why contralateral loss of pain temperature in the body. So this is injury of the spinothalamic tract, which is a cross tract running contralateral. So problems will be contralateral. And why do we have the ipsilateral cerebellar ataxia? Why she keeps falling to the same side of lesion? Why the heel shin test is positive on the same side of the lesion? Because this tract, which is dorsal spinocerebellar tract compromised, so ipsilateral ataxia features on the same side of lesion. Also notice that there will be a problem of nucleus ambiguous and having ischemia. So the muscles of the palate, pharynx, larynx will be compromised on the same side, and there will be difficulty speech and swallowing. Also, you will notice that there is ischemia of nucleus tractus solitarius, so there will be loss of taste sensation on the same half of the tongue. And she will be having vertigo also, because even the vestibular nucleus is in the lateral medulla. So you see, she's having a lot of problems like vertigo, loss of taste sensation, difficulty speech swallowing, loss of pain temperature, same side of the face, and also there is ataxia on the same side. Only some problems are contralateral, which is pain temperature loss on the body, because spinothalamic tract is running contralateral. Why she is not having a problem of the five sensation carried by dorsal column medial lemniscal system? Because this is the dorsal column medial lemniscal system and it is not having ischemia. It will be affected in medial medullary syndrome, not the lateral medullary syndrome. Similarly, she has no problem of the pyramidal tract. There is no spastic paralysis, because spastic paralysis will be a problem of medial medullary syndrome, not the lateral medullary syndrome. Similarly, she will not have a problem with the tongue muscle, 12th nucleus, because 12th nucleus is near the midline. So it will be a problem of tongue muscle palsy only in the medial medullary syndrome, not the lateral medullary syndrome, what she is having right now. Here we are going to talk about the ANS, which is a sympathetic and a parasympathetic system. And remember that the sympathetic is thoracolumbar flow, and whereas the parasympathetic is craniosacral flow. As you can see, this is the sympathetic system, which is having some sympathetic neurons in the thoracic and upper lumbar spinal cord. So the sympathetic system is thoracolumbar flow, whereas on the side, which is parasympathetic system, cranial nerves and the sacral nerve, craniosacral flow is parasympathetic system. So which cranial nerve? That is 3, 7, 9, 10. And which sacral nerve? That is the S234 nervi erigantes. So cranial sacral flow, parasympathetic flow, whereas thoracolumbar flow is the sympathetic flow. Now understand that parasympathetic ganglia are close to the target organs. That is why in the parasympathetic system, the postganglionic fiber will be short length fiber. But in the sympathetic system, since the sympathetic ganglia are close to the CNS, it is a preganglionic fiber which will be short length fiber. Let's understand that only the fibers which come from the CNS are myelinated. So may it be parasympathetic system or may it be the sympathetic system. Only the preganglionic fibers will be myelinated, white in color. The postganglionic fibers are non-myelinated fibers, maybe parasympathetic or sympathetic system. Remember, maybe the sympathetic or parasympathetic, they use acetylcholine at the level of the ganglia. But if you come to the level of the target organ, acetylcholine is used by parasympathetic system because the sympathetic system is mostly adrenergic pathway. Though we have an exception if you're talking about the skin, because the skin will be using acetylcholine. But still, remember that the sympathetic system is mostly adrenergic and rarely it is cholinergic at the target organ effector level. Now here we are talking about the cranial and the sacral flow. The 3, 7, 9, 10 nerve and nervi erigantes, S2, 3, 4, which are also called pelvic splanchnic nerve, as they supply pelvic viscera like urinary bladder and the uterus and the rectum. If you activate them, there will be urination and defecation, because parasympathetic system is for bladder bowel evacuation by increasing peristalsis and relaxing the sphincter. Now, number 3 will have the Edinger-Westphal nucleus in the midbrain and sending preganglionic fiber through the oculomotor nerve to the ciliary ganglion and controlling two smooth muscles, which are the sphincter pupillae and the ciliaris muscle. So sphincter pupillae for light reflex and ciliaris muscle for accommodation reflex will be the two smooth muscles controlled by ciliary ganglion, and the preganglionic fiber carried by the third nerve, oculomotor nerve, from Edinger-Westphal nucleus in the midbrain. Whereas the seventh nerve is having superior salivatory nucleus in the lower pons and having two ganglia. One is called as the pterygopalpine ganglion, and the other is called as the submandible ganglion, controlling 5 glands on the face. The pterygopalpine ganglion controls the LNP gland, that is lacrimal nasal palatine gland, whereas the submandible ganglion controls the sublingual submandible salivary gland. These 5 glands on the face, controlled by 2 ganglia, are controlled by one nucleus, superior salivatory nucleus, in the lower pons. Whereas there is an inferior salivatory nucleus in the lower pons for the ninth nerve, and preganglionic fibers carried by the ninth nerve to the optic ganglion and then controlling the parotid salivary gland. Tenth nerve is the dorsal nucleus of vagus in the medulla oblongata and the longest cranial nerve, the vagus nerve, and it is supplying the head neck region, thorax, and the abdomen region. In the thorax, it is cardio inhibitory and it is also causing bronchoconstriction in the lungs. In the abdomen region, it will supply till the midgut, till the right 2/3 of the transverse colon, whereas the splenic flexure and the rectum part, the hindgut, will be under the nervi erigantes, which is also called as the pelvic splanchnic nerves. Remember, number 3, 7, 9, 10 or nervi erigantes, they can carry only preganglionic fibers and they are white in color, whereas the postganglionic fibers are carried by some other nerves. For example, in the head and neck region, the postganglionic fibers are carried along with the branches of the trigeminal, which has topographic relation. Number 3, 7, 9, 10 are all functional nerve, and trigeminal is the topographic nerve. Now, this is the sympathetic system, which is thoracolumbar flow, which is 12 thoracic and 2 lumbar on each side, so that there will be 14 preganglionic fibers on each side, total 28 preganglionic fibers. You will notice that the hypothalamus is having the first order neuron and sending it to the spinal cord. Spinal cord will send the second order neuron, which is either going to synapse in the paravertebral ganglia, which is for controlling the skin effectors, or in the prevertebral ganglia, which are going to control the viscera. Let us magnify this area now. So it is starting from T1 to L2, and there are 12 thoracic and 2 lumbar fibers, 14 fibers on this side, 14 fibers on that side. So total number of preganglionic sympathetic fibers are 14 plus 14, 28. And these are called white ramus communicantes because they are myelinated fibers coming from the CNS, but the one which come from the sympathetic chain will be gray ramus communicante because they will be non-myelinated fibers, like coming to supply the skin effector hair, like sweat gland there. So as we can see, there is paravertebral ganglia, which are to control the skin effectors, and there is the prevertebral ganglia, which are actually in the midline, but you have pulled it to one side and they control the viscera. For example, this is the ciliary ganglion around the celiac trunk for supplying the foreguts, and this is the superior mesenteric ganglion around the superior mesenteric artery, supply the midgut. This is inferior mesenteric ganglion around the inferior mesenteric artery, supplying the hindgut derivatives. Let us look at the greater splanchnic nerve, having 5 root value, starting with number 5. Thoracic 5. Thoracic 5, 6, 7, 8, 9. 5 root values greater splanchnic nerve is coming from the CNS. So it will be myelinated fibers, the preganglionic fibers, and then they are white in color, passing through white ramus communicante, leaving the sympathetic chain and synapsing in the celiac ganglion around the celiac artery. The celiac artery branches will carry post-ganglionic fiber to the foregut derivatives like the stomach and cause sympathetic storage. Sympathetic storage is by reducing peristalsis. So there will be stomach distension now, which will lead to pain, and that pain of stomach distension is back carried by the same greater splanchnic nerve. First, the greater splanchnic nerve was reducing peristalsis so that there is distension of the stomach, storage, sympathetic storage, and if there's a pain, that pain can also be carried by same nerve backward towards the CNS. So this nerve, the greater splanchnic nerve, is sensory motor nerve, mixed nerve. Now let us look at the pathway of vertebral ganglia controlling the skin effectors there. We will see there's a neuron coming from CNS, and that will be preganglionic fiber, myelinated fiber passing through the white ramus communicante and synapsing the paravertebral ganglia. Then there will be a postganglionic fiber to control the skin effector, and there will be gray ramus communicantes. So here we have the lateral horn cell in the spinal cord and giving a preganglion neuron, which is passing through the ventral root of the spinal cord to enter the spinal nerve and leave the spinal nerve through a distal white ramus there. And then it is going to synapse in this ganglion, which is paravertebral ganglion. And from there comes the post-ganglionic fiber, which is non-myelinated fiber, and that is why it is gray ramus communicante, and re-enter the spinal nerve. Go in the spinal nerve and control the skin effectors. You have to understand two things here. The proximal and more medial is gray ramus communicante, having the post-ganglionic fiber, and more distal or lateral is the white ramus communicante, carrying the preganglionic fiber. Now let us talk about the visceral supply, which is by the prevertebral ganglia. They're also called pre-aortic ganglia because they are in front of the aorta. Aorta gives some branches like celiac artery for foregut and superior mesenteric artery for midgut, inferior mesenteric artery for hindgut. Accordingly, we'll have the name of the ganglia which are pre-aortic or prevertebral ganglia. Let us look at one of them now, the celiac ganglion to control the stomach effector. You will notice that again, it is the lateral horn cell, which is sending the preganglionic fiber by ventral root of the spinal cord and entering the spinal nerve there. So passing the ventral root, enter the spinal nerve and leave the spinal nerve through a distal white ramus. As it reaches the distal white ramus, it is not synapsing in the paravertebral ganglia. Bypass them so that it can synapse in the prevertebral ganglia like celiac ganglion. Here, the nerve is called as greater splanchnic nerve to supply the foregut. And then there'll be a postganglionic fibers coming up. The postganglionic fibers will be carried by branches of the celiac artery to the stomach. And there'll be a stomach, reduce the peristalsis and storage in the stomach. But that will be painful after some time. And that pain of the stomach will be carried back by the same pathway, which is greater splanchnic nerve, and then it is going towards the distal white ramus and then enter the spinal nerve, but then leave the spinal nerve by dorsal root ganglion and then reach the posterior horn cell of the spinal cord. So understand that greater splanchnic nerve is a sensory motor nerve. First it was motor to reduce the peristalsis of stomach, and then when there's a pain, it is also a sensory nerve which can carry the fibers back towards the spinal cord. Now let us look at the Horner pathway and then discuss the Horner syndrome as well. You'll find that there is the hypothalamus, which is sending a first order neuron, which is going to be called as hypothalamo-spinal pathway, and then it is going to synapse with the T1 sympathetic neuron. From there, the second order neuron will start, and the second order neuron is going to climb up the sympathetic chain so that it is synapsing at the superior cervical ganglion. This will be the preganglionic fiber, second order neuron. And then the third order neuron will start, which will make a sympathetic plexus around the internal carotid artery so that it can reach the muscles in the eyeball, like you will have the dilator pupillae and the superior tarsal muscle for elevation of upper eyelid and dilation of the pupil. Let us look at one more diagram now for Horner pathway and Horner syndrome. This is the patient who has right-sided Horner syndrome. And in this right-sided Horner syndrome, you'll notice there is a partial ptosis in the patient, and there is a meiosis also. So there is a partial ptosis, there is meiosis as well, and then there is sunken eyeball, which is also called enophthalmos. It is due to paralysis of some of the muscles supplied by T1 sympathetic fibers. Namely, the muscles are dilator pupillae and superior tarsal muscle, part of the Miller muscle, and the orbitalis muscle, which is normally to push the eyeball out of socket. Normally, if it is paralyzed, eyeball goes back into socket, enophthalmos. If superior tarsal muscle, part of Miller, is paralyzed, you cannot elevate the upper eyelid, partial ptosis. And if dilator pupil is not working, sphincter pupillae will work more, leading to meiosis. That is the feature of Horner syndrome. Now, what is the etiology of Horner syndrome? Let us find out. As we suggested, hypothalamus is sending a pathway which is hypothalamo-spinal pathway and is passing the brainstem to reach the T1 sympathetic neuron in the spinal cord. This is the central pathway. It was compromised in the lateral medulla syndrome, Wallenberg syndrome, leading to ipsilateral Horner syndrome in Wallenberg syndrome, the lady which we have discussed a while ago. Now, there's a second order neuron fibers, which is pre-ganglionic fibers, and they'll be climbing up the sympathetic chain so that they can synapse in the superior cervical ganglion. In that process, they are passing over the apex of the lung, and if there is a Pancoast tumor, apical lung cancer, then there will be ipsilateral Horner syndrome. Second order neuron injury, pre-ganglionic fibers compromised. And then you can see there's a third order neuron which is making sympathetic plexus around internal carotid artery, passing through the cavernous sinus and supplying muscles like superior tarsal muscle and dilator pupillae muscle. If there is a cavernous sinus pathology like internal carotid artery dissection, the T1 sympathetic pathway will be compromised, leading to paralysis of superior tarsal muscle, partial ptosis, and also there is paralysis of dilator, leading to meiosis. But remember, in this third order neuron injury, which is a post-ganglionic fiber injury, there will be no problem of sweating or vasoconstriction on the face in the Horner syndrome, because the fibers which are going to do vasoconstriction in the skin and supply the sweat gland in the skin are already given, so they were preserved. Understand that loss of sweating or vasoconstriction is a feature of Horner syndrome only if the injury was something first order neuron, Wallenberg syndrome, or something second order neuron, Pancoast syndrome. But these loss of sweating or loss of vasoconstriction as a feature of Horner syndrome is not seen in this case, because this case, wherever the injury is, only distal problems will be seen and proximal branches are intact, so no problem will be observed regarding the sweating or vasoconstriction.